Wow. Yeah. Hello, everyone. Good morning. Oh, happy stuff.
Do it like you mean it.
Oh, like it is. The chat doesn't leave you at all. Good morning and welcome. I'd say it's a real pleasure and honor to be here with you guys today. And I'm so happy to see so many of the board members. This is one of the few times that we'll be spending a few hours together, mingling and talking and understanding each other and learning as well. So make yourself comfortable in the room and welcome back. Let's see. So we have an hour. I don't know if we need that much time, but an hour to learn a little about each other as to who we are and what we are interested in. And we call it getting acquainted. Should I start? A little about me. My name is Peterson Pierre, and maybe 9.5 out of 10 times I have to repeat my name because the people will tell me, "So what's your first name?" And I was like, "I just gave you my first name, it's Peterson." I was like, "Oh, so what's your last name?" "Pierre." "Oh, so you're Pierre Peterson." I was like, "No." Yeah. And have to do that over and over and over again, whether you have had to do that. I'm originally, I would say, from the Caribbean. I grew up in the Caribbean and migrated in my 20s. So I've been living here for a few decades. I'm in my 60s, so I've been here for a few decades, sure. And I am in this by profession. I have been in acute hospital care for the past 40 years. So I've been working for a little while in healthcare. And I currently work as an associate professor at UCSF, health science associate professor. I am attached to the School of Nursing, but I work across all 5 schools. I have the privilege to teach from medical students to dentistry students to nursing and pharmacy and physical therapy. So I have this broad audience when I have classes. And I have lived in Sonoma County for the past 25 years. Moving here. No, I have to try to think. I have 3 kids and I have 3 grandkids. My grandson just turned 17 this week, Wednesday. Wow. He was like, I was at work and I said, it was like, what? I was like, yes, my 17-year-old grandson and 2 granddaughters. And for my hobbies, I like hiking. So I do a lot of hiking. I travel most of the Caribbean countries hiking. That's one of my passions. And what brought me into healthcare generally, remember when I was about 9 years old, I I spent most of my childhood with my grandparents. This older couple came and this woman was talking about, somebody had surgery and they gave them an injection in the back and they were awake during surgery. That's my conversation, 9-year-old thing, but I still heard that. And I was like, oh, injection in the back, you were awake after surgery? I have to be the one to do this when I grow up. I did not know it was anesthesia or anything. So anyway, that was my interest, and I asked about it, and later I realized it was anesthesia. It was spinal anesthesia that they had at the time. That was way back in the 70s. And then I became a nurse, and I became a nurse anesthetist. I graduated from this anesthesia school 30 years ago, 1985. And I got this anesthesia for a number of years until I transitioned into academia. And during my career, I've also worked as, in management, in leadership, and what documenting behavioral health. having worked in the emergency department for many years, I saw for a long time behavioral health patients were treated as second-class patients. The urgency that it would put onto somebody with symptoms with heart attack or stroke was not the same like when somebody who come in with behavioral health symptoms. Most times they will undergoing for hours, they have not seen a psychiatrist, they have not been transferred. And so that sparked my interest, like, what can I do to make a difference? Where can I go? And doing my master's at Sonoma State, and like one of my professors told me, oh, can go to the behavioral mental health at the time it was called, mental health board. They meet on a Tuesday, and I was like, oh, Tuesday, that doesn't fit my schedule. So I went to the meeting. I was in Petaluma and that day, and I wanted to continue, but I couldn't because I was in the OR and I work 8:30 to 5. It was just not what I could do until I got out of the OR, and then I got time to do that. So, and I have been on the board for a number of years. I have been the chair for I think that's my third round of being chair. Was co-chair for at least 2 years as well. So I've been around for a little while, and I'm still excited to be on the board and to be part of the community. I think that's one way that I give back to the community, volunteering onto the pod, and I enjoy that. And since I am in retirement, so I'll have more time. I'm not going to retire now. I'm already high because I'm heading to the 65, and then thinking of what's next. And education-wise, I did a master's in leadership and management at Sonoma State, and I did my doctorate at Penn State. And that's me in a nutshell. Should I go round table starting done?
Sure. I was raised in complete chaos. Both my parents were severe alcoholics. I was raised in Orange County and San Francisco. Played football at Sir Francis Drake High School.
We went to the same thing. How about that?
I'm the only person in my family that went to college. I have a degree in English literature, a bachelor's in English lit, and an MA in humanities. I've served on several boards. We have 6 children, 14 grandchildren. I've done a lot of work in my main interest is homeless community. So we've done a lot. My wife and I did work with some of the homeless people, and we still are active in that. So my primary interest is people who are living on the street and whatever. I've been active in some community outreach where we go out into the streets and meet with people and help them along the path. I think that's basically who I am. Why I'm here, why I volunteer for this board. Go ahead.
Brad. We went to the same high school, and I just grew up in the same town. I have a completely different narrative, man. I lived a charmed life, living in San Anselmo. Before it was like Marin. My parents were both school teachers, and gardeners were neighbors. The demographics were completely different. But my mom's 94, and my brother and I, we were talking about something, and then she said, I was kind of reflecting, I'm so sorry it took you guys out of high school and moved you from Daly City to San Anselmo. And my brother and I looked at each other and go, are you kidding me? Mom, you really been living with this, man? Thank you so much for that. It's such an improvement. So I don't have any of that background. I'm so glad you, really, I'm really touched to hear your story and narrative. But I grew up in San Anselmo, became a civil engineer, and then did that for 8 years. And I don't know why I got into engineering, but I had this opportunity to change into teaching. And I jumped at that. And in 1994, started teaching in high school at straight high school. So I was teaching at my alma mater. And so I taught math and science. And so retired from that 2 years ago and was living kind of retirement. I was thinking about, well, I've got all this experience with high school kids and I've seen the changes in mental health. I mean, there's clear, for a while there, when I started teaching in 94, people would ask me, hey, are kids any different? And I didn't really think that kids were that much different. I just kind of felt, yeah, kind of the same thing that I felt growing up and going to school in San Anselmo. But I've seen the mental health changes and challenges. Kids these days are so much different than they were in 94, and they're so much different than they were in high school. The mental health challenges, the iPhone, the monitoring, and so I've worked at Drake. I worked at Tamascon, which is a independent study school, and it kind of caters to kids with high anxiety. And so I've seen by experience some of the challenges that kids have. And so I just felt, hey, in retirement, maybe I can, without any experience in this first board I've ever been on, I felt like, oh, maybe I can contribute something. And I'll leave that to you if I contribute. I am in a learning, listening mode, being around Gregory and Peterson and, the experience you guys have, I just absorb it. I don't feel like I have a lot to contribute other than when it comes to something very pragmatic and practical. So, retired, figure, all right, I joined a board. I played bass in a band, it's cool. And then got a call from the district and one of their math teachers couldn't answer the bell in September. So a 3 or 4 week assignment turned into a year-long assignment. So I'm teaching 2 classes down at Tam High School. It filled 3 days a week. But, last thing I want to say, it's freaking awesome. Being a part-time teacher is so much better than being a full-time teacher. I go and I teach the classes. I have relationships with the kids. They're teaching geometry, which is the one class I want to teach, and I don't have to go to a staff meeting. People are so happy to see me when I come in, and then when I leave, they're just waiting. Thank you so much for your contribution. I feel so appreciated, and and which is another thing unrelated, but feeling appreciated in life is so important. And I don't think I would have articulated that till I've seen this contrast from being a full-time and doing the grind of being a full-time teacher to now this ability to have a different perspective, part-time, appreciate, say, wow, that is. And so I've actually been trying to show more appreciation to people because I see how important that is to me. And I feel a little lighter on my feet because of that. So I just try and show that, so I kind of tend to learn by experience. And I just appreciate all of you tolerating my lack of experience and input into some of these very complex matters. So, thank you.
Thank you. Alexandra.
So I also had a charmed childhood. I grew up in San Francisco, 2 parents, excellent education through the public schools. So I feel very lucky for that. And then went to Berkeley and majored in social welfare. And after I was done with my bachelor's, I started working with the unhoused population in Berkeley. That was eye-opening and frustrating, and then we think, okay, we need changes, we need to make policy changes. And so then I got master's in public health and master's in social welfare, and I didn't find a way to make those changes, and I'm still working on that.
Except, would you? So long.
So I started working in healthcare. I ended up in Lake County and then Mendocino County, and then adopted my 2 children, and then adoption and foster care became a passion, and moved to Santa Rosa and started working at TLC, Child and Family Services. And when I was in graduate school, I thought, oh, I'm finally going to find out how to treat mental illness and how to treat substance use. And found out, no, there's no answers, not even in graduate school. the best solution they had for substance use disorder was 12-step programs, and the mental health system sounded like a mess. And I thought, well, I never want to deal with either of those issues. I want to go into child welfare or healthcare, or. But then along came my children, and my son ended up with both substance use disorder and mental illness, and so I've now had a lot of lived experience. So I'm straddling both worlds as having been a professional, but also having a lived experience as a family member and still wanting to make policy change. So that's why I'm here. My dad got sick in 2019 and I had to stop working. So I got to retire to take care of my parents, and they're both now deceased. And I can do the things that I'm most passionate about, which is being on this board. I also volunteer on the board of Positive Living Support, PALS, with my 2 dogs. We go out in the community, and we've met Velvet,
Oh, yeah.
another dog, Linus, and we do a lot of work for mental health in the community, in the schools, at Valley Women Children's Center, various courses, and that's a big passion. And lately, I've also become involved. Well, I've spoken Spanish since middle school, and I've been involved in the Spanish-speaking community. Lately, I've been doing ICE accompaniments for people from our area who have to go to their appointments in San Francisco. So I've been involved with the North Bay Rapid Response Center as well. So I get to do the things I want to do, and I'm passionate about that, and still trying to figure out how we can make those changes. Dedicated to that. So that's why I'm here.
Thank you. Kathleen, tell us about.
Oh, actually, I want
sorry.
to add a couple things. So
No,
my
sorry.
son, the biggest reason I'm here is because of my son, and he started using marijuana when he was about 14 and 13. And he has a strong birth and history of schizophrenia, and I think he has schizophrenia, but it's not been diagnosed. So I've gotten really familiar with the frustrations. He's 26. He's also incarcerated, so I've become very familiar with that whole system. So that's something I want to bring more to the board, is how by default the jail system and the judicial system and the whole courts is basically our entry to mental health treatment these days. So that's a big passion of mine right now. And he just got sentenced finally with a felony. I've never thought I would be happy to say he had a felony, but this means he will have services, and we're waiting for a spot funded by the TASK program, so he will be in some residential treatment. Yeah.
You know, this is chuckling, but I was just thinking about, there's a very strong correlation between prodromal, like kids who have tendency to schizophrenia biologically, and marijuana use.
Yeah, he was.
It can bring it.
I think other drugs. Yeah, too. Oh, he's moved on to other drugs.
Yes.
Yeah.
But that's like,
Yeah.
Yeah, I mean, it's more. I have a friend that has a mentally schizophrenic son. Anyway, my turn. Yes, oh gosh. Well, I grew up in Southern California, and I'm sure you haven't heard of El Monte. Raise your hand if you've heard of El Monte.
I've heard of it.
Yeah, there's a.
I've heard of it. I'm sorry, Kathleen, I've heard.
Not very many people have heard of it. And I grew up in a good Mormon family. The problem was I knew fairly young that I wasn't a Mormon. So I kind of learned to just be private about certain things, shall we say. Now, of course, I get to be who I am. Let's see. Got very young, had a couple of kids. My son is developmentally disabled and bipolar. So that's a fun combination. And probably autistic, you know. He doesn't have all the typical, but I don't know that there is such a thing anymore. Anyway, he was a handful. That got me kind of interested in, I guess, that side of things. Went to school. Most of my career I spent as a school counselor in Southern California and with middle school, which is an interesting age. Switched to high school a few years, you know, anyway. And then have two kids. I have a daughter. And she was sort of, and is an attorney. Anyway, let's see, the last few years that I worked at Sonoma Developmental Center. And my son actually was a resident there. And so when they closed, I became the head of the nonprofit for families and residents to make sure that they all had a place to go. Got to know a few legislators, still have an acquaintance. One of them recruited me, and that's why I'm here. I wish I could say, oh, such a passion to join this board. It's a dream come true, but I have thought of leaving many times. I ran the board. I wasn't a board member. So I feel like on this board, I don't know if I'm contributing. I don't know if I have control enough to satisfy me, so I have mixed feelings, I guess. Everybody else is so committed. But one thing I am committed to, and that's the suicide piece. I've had a family member or two and a close acquaintance or two who have done it. And they were all older, only one female, 3 males. We all know who's doing it, and it's males over 50. They have a very high incidence. And so I joined that subgroup and have really enjoyed that. And I encourage you all, if you are older or are interested, so we're gonna have an event. And the event that I went to and participated in, I thought was very interesting and very good. So I'll let you know more about that. That's in September. Stop much. So that's it. That's all I got.
I'm Angelina Graff. I have been serving on this board since June. I'm here to
Is that?
Rabbit.
Oh,
Or can we not? I'm sorry, I have a thing about.
I'm working on it.
Oh,
We're working on it. Is it because you have 2 open?
Sorry. Okay.
We were switching it.
I work for Sonoma County Employee and Labor Relations Analyst. I am new to Sonoma County. I moved here in 2020 after my kids and I lost everything in a fire in Oakland. I am originally from San Francisco, born and raised. I am from 3 and 4 generations of refugees. So I have a very interesting relationship with being American right now. Yeah. Why there's so much? I have always been in activism in one form or another. When I first started when I was 12 years old, and I wrote a letter about what is it? Tuna safe tuna. That was my first letter writing campaign. I have 2 kids. I don't really have a community in Sonoma, which is why and because my community has always been based in activism or service, it was important for me to put down roots here. I grew up going to the Russian River, but had not had a lot of exposure to Sonoma County as a community. I have 2 sons. We are all diagnosed with complex PTSD. And my husband is disabled and also has complex PTSD. And I have he would have been one of those statistics, for, you know, white men of a certain age. Yeah. And, so I've seen him navigate the system here. He, also comes from a very poor background, which is interesting to see how his treatment has changed since we got married. And when someone has an advocate, how quickly people pay attention. He, yeah, so I'm still trying to kind of find my way in Sonoma County. I am getting, I have my master's of science in organization development from USF, and I'm getting my doctorate, which I'll miss half the day because I have to go to class. And I had class last night till 10. But I'm getting my doctorate in organization and leadership through the lens of social justice. Because I'm committed, my work is representation and public service leadership of minoritized communities, and Sonoma County is my subject. I used to be the human resources director at a Locke psychiatric facility and was terminated for whistleblowing. And that happened when I first moved to Sonoma County. That devastated me, and it pivoted, it kind of, that's part of the impetus for joining the board. I was a witness to how much pressure our behavioral healthcare staff are under, and the impact it has on their families. And so it kind of became my mission to, of course, you know, support mental health in the community, but also really to support behavioral healthcare workers in balancing caregiving and being on the front line. So I'm excited to get to know everyone and help make Sonoma County a little bit better.
Thank you.
Good morning, everyone. Happy Valentine's Day. My name is Becky Ennis. I just logistically, I'm sorry, I'll be standing a lot, so please, I hope that offends no one. I am born and raised Santa Rosa. Here, yeah, I'm an OG. As they say, I'm a mom, I'm an aunt, I'm a sister. I'm a cat owner. I also like to be outside. So, yeah, looking forward to the rainy season. So thank you. And again, I apologize. I will also have to leave after 1 or 1:30. I sent an email late last night, so.
Hi, I'm Lindsay Morrison. I actually grew up in Kansas City, Missouri. Go Chiefs. And then moved to Arizona, I think, in 2004, and started working in behavioral health in 2006 as a case manager for the SMI population. And I've continued to work in behavioral health since. I am currently the Chief Operations Officer for Santa Rosa Behavioral Health Care Hospital here in Sonoma. I've lived here for about 5, almost 6 years now. It's my husband and I do have a daughter, who's 26, lives in Arizona. And we have currently going through the lived experience of substance abuse for the last 6, 7 years of my daughter's life, which has been a challenge. Went back to school, got my master's in public administration and emphasized in healthcare management. And here I am. I wanted to be able to join the board and contribute, as I see a lot of things within our behavioral health system and where I work and what can be done. It's, you know, the hospital stays pretty much full. on a daily basis, which is surprising. We have an adolescent unit and then the rest are adults and it's, I mean, we have like 135 patients today. And so, and we get over close to like 3,000 referrals a month from all over California. So it's pretty sad, but there definitely could use more beds for individuals to get the help we need. So yeah, I'm happy to be here and hope to contribute.
Good morning, everybody. My name is Jason Reed. I am a newly appointed fifth district representative that hasn't been sworn in yet. I'm very, very happy to be here this morning. I am a student as well as an employee of the Santa Rosa Junior College. I am working on a degrees in social and behavioral sciences as well as social work and human services addiction studies. One of the reasons why I am in that major is because I wield quite a bit of lived experience. I am formerly incarcerated. I am in active recovery. So I've definitely dealt with substance use. I grew up with a lot of trauma and stuff like that in my life. So I'm very passionate about not only changing my own life, but perhaps being able to guide others to navigate their own. And so that's one of the reasons I'm here. I'm very active in the culture of the junior college, where there's a lot of work being done around not only social work and human services. We've got a great program there, but also social justice and so forth. I am the president of Students for Recovery on campus. I'm the interclub council representative for the Second Chance Rising Scholars Program, which is for formerly incarcerated students. As well as an advocate in the student organization collaboration for social justice. And so heavily involved on campus for sure. I also do a lot of the work in the community around giving back. I work with Micah's Hugs and opioid overdose reversal training and awareness. I love Micah and Michelle. They're good friends of mine. I also work with Equisense. I'm a co-facilitator for a men's workshop that we put on once a month. I also am very passionate about working with people around suicidal ideation, as well as youth. I'm also a youth mentor. I work with Dr. Mark Schillinger out of Marin County, and we do every year we do the Young Men's Ultimate Weekend for young men. And so I'm very passionate, obviously, about giving back to the community, doing, especially the fentanyl epidemic, suicidal ideation. I love working with youth. On campus, I do work also as I'm a certified peer educator and success coach in the academic counseling department. So that's kind of a little bit of my service. And I very much want to be at the heartbeat of the service that's being provided from this board. I was recruited by Gregory here, and I'm very happy I was. I saw the passion in him when he was speaking to me at an on-campus event. And I immediately started taking the steps to get on this board. It's taken a little while. The wheels in the car have been a little slow, but I'm definitely fine with that. That's patient. I absolutely have loved hearing people check in so far and kind of seeing the different personalities and histories and lived experience and stuff like that. And I just hope that I can contribute from my perspective. Thanks, guys.
Thanks and welcome. Happy to have you on the board.
Thank you.
And hope your time here will be meaningful and purposeful. Sometimes I have to say, having on board for a while, some people get frustrated when things are not moving as fast or when things are not going in the direction. But the wheels of change takes time. And if collectively we are persistent, and we will get there. Gregory.
My name is Gregory Farron, and I've been in the county here for about 56 years, both at Marin County and in Sonoma County. In that 56 years, I've sort of the poster child for either being staff of an agency that provides mental health, substance use, others, or I've been on their boards. So I've been on both the supervisory and direct service. I'm not the guy to give counseling directly to people. I'm the guy to keep things alive. Been in a fiscal director position more often than not, or the treasurer of the board. Partly because I grew up a little rich kid. I was from La Jolla, San Diego, surfer kid.
I know that.
My grandfather gave me $100 million when I was 12. So I started serving on major philanthropic, foundations all over the country. They all wanted my money and they all wanted a young guy. So I became the young guy on a whole lot of foundations. And in that role, I learned a lot about how to evaluate programs, how to make a decision about where money should go. And I gravitated after I came back from Vietnam as a recovering PTSD to be able to help my community. So I found positions that were very low paid because I didn't need to get paid. And it put me in touch with a lot of people just like you. People who were passionate, people who wanted to help, people who mostly had family or other direct connections. And you could see how sincere they were and how giving they were. I, like you, had nothing in my background or family that said, this person's in need of services. In fact, most of my family has been escaping life for most of their lives. I was notified last week that my stepbrother, who left our family when he was about 10, died of a fentanyl dose in San Diego in Presidio Park. So I have one family member who I can certify has had a rough life. The rest of my family had enjoyed the spoils of everything that this society gives. And I've done my best to avoid it. I did not want to be those kids that I grew up with. So I've avoided it, and I think I've done a pretty good job. In the meantime, I've worked for county, state, community agencies, colleges. And so I've had a lot of work experience helping people grow systems. And when several times in the last 10 years, the board of supervisors said, hey, we've got a position we'd like you to be in to advise us on healthcare, on care, everything. I was usually the guy who they chose. So I like to think that people trust me enough to be able to keep telling the truth to everybody and to be able to help people collaborate. That's me.
All right, I'm going to give it out to Jan.
Yeah, okay.
Tell us something about you.
Okay, good morning, everyone. I apologize for being late and some traffic coming up from Sonoma, but it's good to be here and I feel enjoying hearing people's, a little bit of your background because we don't usually talk about this stuff at board meetings, do we? So a little bit about me. I was actually born and raised in Pennsylvania in a little town called Lancaster, Pennsylvania, and actually also, I was probably born, my first language was actually Spanish. So I was born about 6 months after my mother arrived here in this country. My family's from Colombia, South America. And my mother didn't speak any English. And she spoke Spanish. That was my first language. So, but I grew up in Pennsylvania. Why we lived there is a whole other story. I won't go into that. But Lancaster is actually a very beautiful community. And but I came to California in my 20s to go to graduate school. So I have a lot of lived experience within my family, as well as my own lived experience. When I was a teenager, I was a troubled teen. And this is when Kent State happened. My mother was like, oh, she was worried I was going to run off and join the SDS. And so she sent me to South America. She sent me to Colombia to live with my family for a while there to get me away from, negative influences. So actually, it was a great experience to go to Colombia. I lived with one of my uncles and his family, traveled around. it really enhanced a sense of belonging within me that I didn't have growing up in Pennsylvania in this little community. Where back in the 50s, brown-skinned people and people with strong Spanish accents were oftentimes very
It's true.
misaligned. They were, yeah. So very sensitive to that sort of thing because of watching my mother struggle with being discriminated against over and over again. And she was a very, anyway, another story. So they sent me to South America and I came back. And I also, when I was in high school, I saw a therapist. And I think that really, really inspired me. It's like, you know what, therapy really helped me. And I think I didn't know that I was making these decisions as I moved on with my life, but I see now that because of that experience, you will know, like I have probably within my family, we have serious depression and suicide, bipolar illness, schizophrenia, alcoholism, other kinds of addiction. Okay, so it's in my family. I'm very familiar with it, and I'm living proof that therapy works because as I moved on in my life, I was able to marry. I've been married for 44 years, raise a family. I have 2 adult children, both healthy, pretty healthy. They have their anxieties and have their issues, and I have 2 grandsons. So, but in my work, I guess, let's see. I came to California to go to graduate school. I got my therapist license in my 20s. And I have worked in every sector in mental health treatment. My first job out of college was in juvenile hall. I was a counselor in the juvenile hall in my hometown. I've worked in school-based mental health settings. I've worked in group homes. I've worked in psych hospitals. I got a lot of experience in inpatient, working in Oakland at Gladman Hospital in the adolescent unit a long time ago. So then fast forward, I also had private practice for a while. So I've worked especially in public sector. Before I came to Sonoma, I worked for about 25 years in Contra Costa County. And I'd say the first 18 of those years, I worked in youth and family services, doing family therapy, group therapy. I ran a girls' residential program for the county. These were girls from juvenile justice system that were adjudicated for committing crimes, and then they came to Chris Adams Girls Center for treatment and rehabilitation. So that was a really exciting program because that was like back in the days when there was a lot of funding available for programs like that. And there was also a mutual interest by the different system partners to contribute. So this was a program that probation threw money into, education threw money into. The CAO of Contra Costa County was very much supportive of Chris Adams, the Board of Supervisors, and I birthed it, I raised it, and then I had to put it down because in budget cuts in 2009, we had to close Chris Adams Girls Center. Okay, so I've lived it, and I was like, that's why I was like, with budget cuts, been there, I know what that's like. It still will make me tearful when I talk about Chris Adams because that was a real labor of love, and it was a great program, and we helped a lot of girls. Then after let's say the 6 years before I came to Sonoma, I was a chief of adult services in Contra Costa, and I came to Sonoma 4 years ago. I've been in the position as a behavioral health director here in Sonoma, and I really love it. What I like most about it is that I'm able to integrate and use a lot of my experience from the past, whether it's my experience as a therapist, my experience of a family member, of having family members with serious issues, and also my understanding of systems. So in terms of how systems keep changing, Brad, you were talking about how things were a long time ago, how they are now. And the systems have changed and. But we always still have people in the community that need mental health treatment. They need substance use treatment. There's always gonna be people that need that. When I was working in youth and family services in Contra Costa, one of my jobs was, I was a liaison for hospital liaison. And so I was responsible for managing the kids that were going to psych hospitals. And also back in the 90s, Napa State Hospital had an adolescent unit. And it was actually a really, really well-run unit. And so we had teenagers that really needed that extra kind of treatment. We would have to conserve them, which was a big deal to conserve a teenager, and they would go to Napa. So I remember taking the last youth to Napa State before they closed that unit. That's very sad because that kind of treatment, I know it's not popular to say, okay, we need state hospital beds for teens, but that kind of treatment, there's a small percentage of kids that really need that kind of treatment, and it's very expensive. So our system is really challenged right now to find the right kind of treatment settings for those kind of youth. It's big,
It's a big deal.
yeah, so one of my pet peeves is, as when I get up into the system stuff as a director, is that, our legislators, they make decisions and they decide on laws that impact our systems without knowing all the details, you know? And there's these unfunded mandates that they have dumped on counties without thinking it through, or without.
I don't think they want to know the details, because if they want to know, they know there are people out there who know the detail,
Yeah.
who can give them the detail. They're not interested in that. That's my
Exactly
I think there's a couple people in here that would agree with me. So anyway, so kind of like always, trying to, yeah, okay, I think we can do that. Okay, we're gonna do our best to implement, you know, SB 43 without funding, that kind of thing. We're gonna do our best. And at the same time, like, but gosh, I wish they would take a little bit more time to think this through and talk to more advocates. So this board is really important because this is where it starts. You know, you talk to your board of supervisors, they talk to CSAC, and they talk to legislators, blah, blah, blah. So then it goes up the chain, but this is where it starts. So it's good to be here. Let me see if there's anything else. So as the director, the division director of behavioral health, I'm responsible for the whole division and the mandates that we're, you know, required to fulfill, as well as the well-being of the staff. So, so anyway, you'll learn a little bit more about us when I present. And I can give you more details about some of the stuff that we're struggling with in the division. So thank you. Yeah.
Thank you very much, Jan.
Yeah.
I remember when Jan came to Sonoma County, came to the board 4 years ago. I think I met her when I started a retreat. I think that was one of the retreats.
Yes, the first retreat, we was at the park.
It was at the park,
Yeah.
Howell Park. It was
Yes,
open
that
for
was nice.
summertime. It was great. Next, would you like to tell us a little more about yourself?
Oh,
I know you're not
I'm not on the board.
Yeah.
I'm a citizen, just keep showing up.
Tell us who you are.
Sure. My name is Shayna Kirk and I am a citizen who's also a parent with children in the Santa Rosa City Schools District. So as you can imagine, I'm quite concerned about the behavioral health services being cut by 90% at a recent board meeting. So yes, I keep showing up. I keep sending emails to folks on various boards, to the Sonoma County School Superintendent. I met with Chris Rogers yesterday. I'm trying to continue expressing my concerns because, yeah, that is a main concern of mine about how the children are going to function 12,000 students without mental health supports. You know, they're going to be without any elementary school counselors or supports. You know, I won't go into the finer details because some people at meetings have already heard me express this. I'm a elementary school counselor this year at Mark West District. I also run an organization supporting trans youth, and that's a major passion of mine. So part of the meeting yesterday was advocating for funding for trans healthcare. So that's a big thing that I support. Yeah, and so I'm just glad to be here. Thank you so much.
Thank you. So we will, our dearest clerk who had been with us, I just have to confess, I told her this morning when I walked in, on my way here, I was thinking of the number of clerks I have interacted with, which is, she's the fifth. And I had to confess, so I said, you're the fifth person in terms of clerk, but you are the one I have felt more connected with since I started. And it was like, oh, but I have to say it in the open because I said it to her. I was like, So I'm very happy to have Sapta with us. So tell us who you are a bit and your background.
Appreciate that. A little about me. I am the proud daughter of immigrants. I was born and raised in Mexico, Ensenada, and I moved to Sonoma when I was 8 years old. I went through the whole having to learn English as a second language. And so it was very difficult at the time to be the daughter of immigrants in Sonoma, which is predominantly white. Got bullied a lot. So I got out of school as fast as I could. I graduated early. At 18, I decided I was going to be a hairdresser because my best friend was going to be a hairdresser. So off we went to beauty college. I became a hairdresser / esthetician. Did that for quite a few years, and then got into private home care in Sonoma. Didn't really care for the whole hairdresser thing. So I took some time off to raise my son and homeschool him. And that's when I decided to become a pastry chef. So I did that for a few years, and then got a job at Rincon Valley Unified School District as an parent liaison is what they called it at the time. I also taught English as a second language for quite a few years, and then shifted my attention to becoming the interpreter for the district. And my main focus was in IEPs and special education. I then I did that for 13, almost 14 years. Then I got a job at Seneca where I was a parent partner, and worked with a lot of families with troubled youth. And then 4 years ago, I was hired by the county to become the assistant to the medical director for behavioral health services. And I also work very closely with Jan. And then I got promoted to be the clerk for the board.
Carry that.
So here we are.
Okay, thank you so much. For all what you do and help us facilitate things on the board. And we have our dear guest speaker. Would you like to tell us a little about yourself?
Okay. Yeah, I'm Teresa Comstock. I'm the Executive Director for California Association of Local Behavioral Health Boards and Commissions, and currently the President of the California Coalition for Behavioral Health. And I got started on a local board in Napa County. It was a mental health board at that time. Before coming to Napa, I had been living in Texas, and my parents were in Napa. My dad worked at Napa State Hospital. And so it was just an interest of mine, and learned a lot about how the issues in Napa County were really statewide issues that we just needed more work on the state level, so got involved that way. Personally, I do have a son who he has a lot of pain, that chronic pain. So he's had issues related to anxiety and depression as well, I think related to that. And as it started happening in high school, we had a really hard time finding any type of psychologist for him. Couldn't find, and we ended up, going out like over an hour away and paying out of pocket. And not only did the psychologist want to meet with him, she wanted to meet with us. So we were paying sometimes $300 a week, just to give him this type of care. And then once he turned 18, he stopped, and then wanted to find somebody for himself. It took a number of years before he found somebody that he would meet with. So had some issues with just access.
Thank you. I'm happy to have you here today and looking forward to you educating us on the Brown Act. And I'm sure we have some questions and we hope to have some lively discussion. And as we wrap up this session, we have another 5 minutes. What will we do in that 5 minutes? We want to take a break. We have a break coming up after Jan. I would say, tell us one fun fact about you. Just volunteer one fun fact about yourself. I like to start this person. One fun fact about me. I was delivered by my great grandmother, who was an old midwife. She tricked my mom from going to the hospital and said, I'll tell you when to go, I'll tell you when to go, I'll tell you when to go. And she was preparing for the delivery all the time. And when my mom said, look like I'm ready, she's like, okay, come over. And she took the delivery at home. Sorry about that. Yeah. Yeah, that's one fun fact about me. Anybody else want to share?
I've never had a cup of coffee in my life.
Oh.
Weird. I used to lie. Yes, I have this energy drink that I like, it's cold here, I have my ice water, and that's it. But yes. I have no desire for lattes, mochas, coffee. I tasted it, I think, at a very young age, and I did not like the taste of it, stuck with me.
That's me with alcohol. When I was 10, for Christmas, I saw that the adults were going from house to house, so I followed them house to house, and I tasted everything I could taste. I tasted, and by the end of the evening, I felt I was dying. I got home, and grandma looked at me and said, what's wrong with you? I said, nothing. She said, something is not right here. And I vomited, I had diarrhea, I had everything, and I'm like, that's it. Since then, I've never tasted her. And my 17th wedding anniversary on the cruise to Alaska. When you go to those cruises, they have special. So I thought, now I'm going to have a drink tonight. I'm sure I'm going to have a drink tonight. So I went, had a lovely dinner, and I said, I'm going to take some champagne. As soon as I took the glass, raised it to my mouth, my whole meal just went the same experience that I had then. Many months ago, came back and I was like, that's not going to happen. Again.
Body knows.
My body doesn't know.
I have something, people, when in my 20s, I was still living in Lancaster. I don't know if people remember 3 Mile Island, when that happened, the meltdown at 3 Mile Island. Well, and 3 Mile Island is about 25 miles from where I was living, okay, so. So our community was very, very active in the anti-nuke movement. And a group of friends and myself, we formed a theater group, a guerrilla theater group, and we would go out and do guerrilla theater and show up places. And so our big star event was, we ended up getting up, we ended up performing on the stage at a big rally in Washington DC, an anti-nuke rally. And Ralph Nader he was waiting in line to get on the stage, and my sister was also in this troupe, and she was a nuclear reactor. We had her, she had her in this box costume, and Ralph Nader helped her go up the steps.
Oh.
So anyway, that was fun.
Oh.
It was a different time, yeah.
Anybody else have another minute?
I have an interesting history. My mother is German and came here as an adult, and my father is German Jewish and came here in 1937 when he was 2.
Wow.
As a refugee. And they met in New York City and got married, and much to the chagrin of my father's family. So it's kind of interesting. I have both backgrounds, and I'm glad my father's not alive anymore to see what's happening in our country now. But my mother passed away a year ago, and it was interesting to see her watch what was going on TV, and she got really mixed up. She had some dementia, and she got mixed up about the current versus what she grew up with. So you have to watch out for those people in those crowds, and so that's been an interesting dichotomy.
All right, guys.
Becky wanted to.
So my
share.
mother's dead now too, and so I'm glad she doesn't have to see some of the stuff that's going on with ICE again.
Oh, yeah.
Yes, maybe we like to.
Oh, I was just gonna say, my fun fact is Jen has lived in Lancaster and New York, and I know all about the red and white roses.
Oh, yeah. When did you live there? I think.
98 to 2000.
Oh.
I was already gone now.
It's like the people that I know. Anyway.
Very well, yeah, there you are. My ex-husband's family's from York, and his mother actually did join us, yes. She gave him nightmares and was on the rainbow,
That was a hotbed of anti-war in Leicester because of the Mennonites and the Amish. So there's really strong pacifists, and so there was like this hub of anti-war stuff in Leicester.
yeah, it was actually a preacher that.
It was a minister, yeah.
Yeah, minister.
Definitely some ministers that from the Mennonite church.
Yeah. My first job, we can see picture, I was late at work because I was stuck trying to behind the horse. In my truck, I couldn't get around him, and I was like, oh, this is a thing now, I guess.
Yeah.
Okay, guys, as we wrap up, we'll, yes.
I'm gonna take a bio break for a minute.
Oh, yeah, okay, take a bio break, 3 minutes.
Thank you.
Yeah.
A bio break.
Right back.
I was wishing everyone else. I know my.
I brought my box.
They lost my name.
Okay.
So bad.
You must have a lot of money.
Yeah. Well, it's all back of on my phone, like $28.
Yeah.
Fine.
What do you think of the choice?
It's really good.
To participate.
Yeah, it's really good. It's, I was like, so I do not. Oh.
Just because of the sweetness of it.
That's enough snacks, so we can,
Yes.
that is nice.
Sometimes go.
They can some flexible.
Definitely.
They have some huge grapes.
I think matter.
And they're all going.
Just like.
Peterson, we're in the Caribbean.
I like to think before I say it.
I
My,
sometimes go back because I want to think more later on.
Ex-father-in-law, is from Dominica.
Oh, Dominica, that's, yeah, okay, that's one of the islands apart from us.
Decide, not as part of it,
Yeah.
but it's fine.
And where in San Francisco do you grow?
Sunset, oh. That was the sunset. Good.
It's just like
St. Ignatius College Preparatory.
Yeah.
Yes.
My wife's.
It was one of the,
That's always my goal.
regular kids.
So what?
I was the, final girls class to close it. My oldest brother, was still there.
No worries.
My middle brother actually
Sorry, but enjoy your time with your family.
started
Yeah.
the girls.
Yeah,
with girls.
there's more on my
and then,
you know, it's Valentine's Day.
But finish the cycle of 4 years, something like that.
First half of the day.
Oh.
But yeah, yeah,
No, I know, my partner was like.
Jesuit, yeah.
Valentine's Day, you have to work.
Yeah,
on
the Jesuit
But I-
tradition is very much, and I'm not
I know.
Catholic, I'm not Jesuit, I was raised Russian Orthodox, but.
Huh.
There's a traditional service.
So I'll just.
That really resonated.
Next slide, kind of.
Yeah.
That way I don't have to, we don't have a, we don't. Yeah, no, I got you.
There's only, and
And
they
it's-
have the printed.
the printed,
yes.
yes.
Let's put it all out.
So
Yeah,
tell me
it's
about
good.
Drake High School.
Yeah, for now, or, you know,
It's no talk there.
I get 94 to go, about. Transfer. They remember. And then I teach at Timscal, which is over by Reading High School. In that same district,
And,
smaller classes.
yeah, they met my
kids,
dad.
You get pro tennis players in training and also
Kids
get
that make fun of the cheerleaders.
issues.
Practice that I've learned.
About yesterday. My mom was a big
Yeah.
rock that makes sense.
I lived in.
It's funny because my mom.
I worked in.
I kept my as a teacher.
When I would come home crying about
And then
getting.
And then I joined.
Player, so this-
Communist therapy that.
So
Yeah.
my kids were born in
Yeah.
different states.
She was in trauma, kids learn new stuff, so that's how she got older.
Did you meet him in any? That's teaching.
Oh, yeah, that's why I was.
Yeah, yeah.
Yeah.
I didn't have to. Actually, he came over.
Yeah,
Yeah.
there you go. Yeah, after being in Eastern Kentucky, this really good change.
No, good for you. You know, I had one teacher, it was not English teacher. I put it all on. She was. I was an engineer. I was struggling and.
Kaiser recruited us.
He, I wanted to, I went, saw him out office hours as a freshman.
Let me know when you're ready.
I'm great.
Okay, guys, shall we reconvene after our bio break?
We can't say, right?
I don't want to sound too professorial.
You might have.
We're now to Jan. Your attention is very kind.
Yeah, well, it's fun.
But I rarely.
So Jan, the floor is yours.
Thank you.
And just, sorry to interrupt, but just FYI, you all have a printout of the slides that we're gonna be showing just because it's kind of hard to see.
So, so I offered to do a presentation on behavioral health, our system of care, because you know what? Our system of care is so complicated, and this is a real high overview of stuff, but, when you have questions, please don't hesitate to ask, because it is complicated. And I hope that this is informative, and we'll see what happens, okay? So welcome to behavioral health. We'll go to the next slide. So I asked that, I said, please think about these slides, because the print is so hard to read on the screen. But you know what?
I got this.
You know what? It's also hard to read on the printout, okay, kind of like, but you can read, okay, so. This is just one, I just want to put behavioral health in the context in which it lives, which we are part of the Department of Health Services. So, we have behavioral health, we have public health, and we have homelessness, services division, as well as several administrative units. So that comprises, the Department of Health Services. And so up at the top is Nolan Sullivan is the director. He's my boss. And this, this slide has to be updated. Karen Smith is no longer our public health officer. We have a public health officer now, Michael Stacy.
Masha McCarthy is not interim, she is a compliance officer. Okay, so, and all of the rest of this is accurate. So over here on the left that's behavioral health. Now, it's just one kind of looks like a small oblong, okay, but wait till you see all the pieces that are inside behavioral health, and we'll be seeing those in a couple minutes. So, homelessness services section, it's homelessness services we're working on integrating homeless services into behavioral health. So that's one of my projects right now that I'm working on. We hope to have homeless services integrated into behavioral health by July 1st. Yes, yeah. And all of these programs would be absorbed into over here. It would be become sections. You'll see later what I mean by that. So Desiree Holstrom is right now, she's the interim division director, but the plan is for when homeless services comes over to us, they're not gonna have a division director anymore. They're going to create a deputy director position who will report to me and they will oversee the homeless services section. Then Dr. Kaplan, we have two assistant health services directors, Gabe Kaplan and Jennifer Pimentel. So they oversee administrative units, contract units, human resources, health data and epidemiology, all that kind of stuff in there. And we have public health. And right now too, there's a big push, I think, because of Proposition 1 to try to break down. We don't create silos between the divisions. They just happen, I think, because of the way funding streams are happen. But we're trying to break those silos down. So for instance, bringing homeless services over into behavioral health, and other places with public health, we're trying to work on some projects together with public health, like the Narcan vending machines that you've seen up. So because we're also distributing Narcan like crazy in behavioral health, and so is public health. So hey, let's combine our efforts and do that together. So that's an example of how we're trying to work together. And also, so that's a little bit about the big picture of how we fit into Department of Health Services. The next slide, please. So this is our role to, so behavioral health really, our mandate is to provide mental health and substance disorder services to Medi-Cal beneficiaries and those who don't have any health insurance. So we offer a whole spectrum of services, as the slide says, from prevention and early intervention, treatment, recovery, and then back to the community. So, but our mandate really, I thought this was clever when I created this slide, but there's two more paragraphs that should kind of click on the
Next one.
Yeah, and just click on, there we go. So our mandate is we're responsible for providing services to the seriously persistently mentally ill adults and severely emotionally disturbed youth. So if you are in the mild to moderate range, we are obligated to, if you come to us for an assessment, hey, I need services, yes, we will provide an evaluation and we will do an assessment and we will determine the level of care that you need. If you're in a mild to moderate range, we're not going to see you in our programs, okay? We're going to make sure we're going to transfer you to partnership healthcare, and they have a whole network of provider network that they will refer people to get treatment for people who are having mild to moderate. If you're in the moderate to severe, then we see you in our programs.
So the assessment taking place?
We have an access unit.
Is that like the,
We have a youth access and we have an adult access. We have, the adult access unit is over at the lakes, next door to our crisis stabilization unit. And our youth access team is in our youth and family services clinic. So those assessments are done there.
and how many, like the CSU, I'm familiar with that. Like how many, they like can hold people there for a certain amount of time before they get transferred somewhere.
Yes, 23 hours and 58 minutes. 59 minutes really. So technically, yeah, that's true. And crisis stabilization unit is really, what it's supposed to do. It's supposed to help people stabilize who are having a psychiatric crisis. And if they don't stabilize within that 23 hours and 59 minutes, technically, then we really need to discharge them if they're doing better. Okay, and which many people do discharge after they've been at the CSU, they go home. Sometimes they need a little bit more, so we have crisis residential programs. We contract with Progress Foundation. Yeah. Yeah, so we send people to crisis residential, but we also have a PUF, it's psychiatric health facility. So we have a lot of acronyms in behavioral health. So when you go, what is a PUF? It's a psychiatric health facility. That we contract with Westwood to operate our PUF. It's out on the Los Coast campus where the juvenile hall is. And the PUF is a 16-bed facility, so you can imagine it fills up pretty fast. And then we start sending people to private hospitals where we have a contract with San Luis Behavioral. And fortunately, they take adolescents as well as adults over there. So we use Santa Rosa Behavioral. So, it's all in here. That's good. Those are great questions. Yeah. So this is just some data points from last year. So we served about 6,000 people. And 72% of those were adults, 26 and over. And then our TAY, 18 to 25, TAY is transition age youth. Okay, and about 11%, and then youth under 17, 16%. So basically you can see that our adult system is 2/3 to 1/3 of the youth. Okay, so really, ideally, we want our youth and family services to really do early intervention and get those kids early to help them, to keep them from moving into the chronic adult system where chronically mentally ill adults are very, very challenging to treat. So, okay. All right, so this slide is just, this is also like little friend, sorry. This is a map of Sonoma County, and this is just a little bit of demographics for folks to see visually, like technically, really, Santa Rosa in the central part of Sonoma County, we serve about 56% of our clients are from Santa Rosa area. And then in the north, about 6.5%. South, 16%, west, about 4%, and then east is another 4%. So east and west, small, similar in percentages. And remember that these are percentages of people who are enrolled in Medi-Cal and are also wanting specialty mental health services, which is what we provide in the. So next slide. So the way our service delivery reflects the demographics. So in Santa Rosa, we have our main campus at the lakes, and that's where we have access. We have adult services, we have youth and family services there, substance use disorder and recovery services, mobile crisis, and our crisis stabilization unit. So all of that is all co-located there at the campus at the lakes. And then we have satellite clinics, one in the north in Cloverdale, one in the south in Petaluma, west in Guerneville, and then east in Sonoma. And then we're also in Santa Rosa, we also have the Orinda Detox Center that's over on Leo Thomas next to the administration building.
Dan, how are the clinics, the satellite clinics, how are they being operated in terms of hours of operation, staffing? I'm assuming the main campus, there's people there all the time, yes.
The main campus, yeah. So the,
Satellite,
that's a good question. So the satellite clinics, so Petaluma and Guerneville are probably the busiest. Petaluma is very busy. As you can see, there's about 16% of our beneficiaries we serve in Petaluma. So Cloverdale that's in the north. I think that's your region. Yeah, so Cloverdale is a very small clinic. And so, that clinic technically should be operational like from 8 to 5, Monday through Friday. Yeah. And we have a psychiatrist who does see the clients there. And that's the psychiatrist who sees those clients mainly is working remotely. So most of our psychiatrists provide remote virtual, not in person.
I thought, you know, the health clinics, this health clinic, the big one in Santa Rosa.
Yeah.
There's several, a couple on Dutton. They do some mental health stuff too.
They do.
How does that play into this model? I get real confused by that stuff.
That's a great question, Kathleen, and that's exactly the kind of stuff that confuses everybody, even someone like myself, you know, it's like, so how that works is that those are FQHCs, so those community health clinics are federally qualified health centers.
Right.
And they provide mainly primary care, and they also are the hub for people who have to provide care to people with mild to moderate. And most of those clinics are operated by partnership health plan. So in Sonoma County, the health plan, the primary care health plan is operated by partnership health plan. And also now we have Kaiser. Kaiser's doing some as well, for Medi-Cal.
They do mild and moderate.
Mild to moderate. So we partner quite a bit with the partnership because of the no wrong door policy, meaning doesn't matter what door you come in, you're gonna get an assessment and we're gonna determine the level of care you need. So sometimes partnership sends people to us and sometimes we're sending people to partnership. Okay, so the partnership is the health plan that operates those health centers.
Likewise with Kaiser, there's that relationship
Pfizer,
too.
yeah, so.
Okay, cool.
Yeah.
In fact, the agreements between partnership and Kaiser went to the Board of Supervisors 2 weeks ago.
Hmm.
Defining that kind of, let's work together partnership.
It's kind of, Kaiser is learning to partner. So partnership is a great partner. I have to say Kaiser sometimes is they've been really challenging, but they are working with us. They are.
There's some movement now.
There's some movement. It's a little better now than it was a year ago. Because they've been used to operating what's called commercial insurance. So
Right.
then they start being providers of Medi-Cal. And we're just a different bear, you know, so, yeah, so.
They told me they would take a Medi-Cal client unless the family was already a Kaiser client. So, I don't know, back in the day, I don't know if that's changed. It's interesting, yeah.
Yeah, well, it depends on your family member's coverage, like what kind of Medi-Cal they have and coverage they have, so. Okay, so we can dive into that later if you want to in terms
That's
of.
okay,
Yeah.
I think you've answered my question.
Okay.
Mild to moderate.
Yeah. So for instance, like in Sonoma Valley where I live, there's the community health center. And so then we work together with them to, again, step up or step down. So if they have clients that are suicidal and some suicidal youth, those young people get referred to us and then our CAPE teams try to intervene with them. And then if we have kids that, you know what, this kid's doing pretty well, they just need some support, they're doing much better, we step them down. So that's really the role of managed care, is we want to reuse our resources as best we can, because we just don't have it. We don't have as many as we'd like. Okay, so.
I have a question. As you said, no wrong door. Is that a new concept?
Yeah, no, so, back as, yes, it's part of CalAIM, so California Advancing and Improving Medi-Cal. So CalAIM was an initiative that was, initiated, back in 2022 to improve Medi-Cal. How Medi-Cal is organized and how we deliver it, so a lot of the improvements are very good, they're very, the system really needed to be changed. But there's a lot, again, you know, it's been a real challenging time to do those kinds of initiatives. So No Wrong Doors is one of the ones that wanted to make sure that whatever door you go into the system, you're gonna get services. And, because in the old days, if you came to one of our clinics and you really didn't meet the criteria, then you didn't meet the criteria. It's like you weren't, there was not a.
That was the end of it. You didn't meet the criteria,
Then
you're left alone.
You're left alone. There
Yeah.
was no path for you to like, here, you need to go over here and get. So No Wrong Door forced the health plan, like partnership health plan and the mental health plan, to work together and work on problems together. So that was No Wrong Door was like 2023. So in 2022, we improved documentation standards, which is fun. We did well. You should have seen it before then. Like, I was, you know, when I was a therapist, I had to do all that stuff. It's like, okay, so they did change documentation standards to improve them. And then, the big one was payment reform was back in 2023, No Wrong Door in 2023. It's been a big one for the system, you know, so.
The Kaiser used to be like this own separate world
Yeah.
of mental health. If you were Kaiser.
Yes.
You went into their ER and they would refer you to somebody they might have a connection with, or you became, yeah. They were like their own world. Are they changing that?
Yes, they are. So they, especially now that they've opted in to be a provider of Medi-Cal services, for certain,
They changed.
they've changed.
Yeah.
So one of the things, for
Things are
instance,
changing.
one of the things that we partnership with, and now with Kaiser a little bit on this one, so, the treatment of eating disorders. So the treatment of eating disorders is, really challenging because we don't get that many, people who have an eating disorder in a year that warrants us to have like create a contract and do all the kinds of things that you have to do for treatment. So we have we have a process called BRS anyway. So we work with partnership on, if we have a client that needs treatment, partnership pays for the healthcare part of the treatment and wherever that client needs to go, and we pay for the mental health treatment. So that's one of those things that came down from the state through CalAIM, like, hey, you guys need to work together. I'm like, yes, thank you. This is like, behavioral health cannot carry all of this, because residential treatment for eating disorder is very, very pricey, and rightly so, you know, it's very intense. So anyway.
I have a question. Does the No Wrong Door, concept also extend to, homeless services centers, such as like the Wellness Center on Scottsboro Road, the Drop-In Center downtown? Is there people there that can assess as well?
So Wellness Center we have Wellness Center on our Lakes campus, and we contract with, West County to operate the Wellness Center.
Okay.
So Wellness Center doesn't do assessments, but many of the people who use the Wellness Center have been assessed, and they're part of our system.
Okay.
They have a doctor and they might have a team connected to them,
So then they would be making probably referrals
Yeah.
for if that came out favorable.
So then this slide this just is a menu of the services that we provide in the system. Youth and adult, pretty much basic, individual and family therapy, group therapy, case management, psych and meds. And in youth, we have therapeutic behavioral services. So there's there's the access number, 707-565-6900. So if anybody wants to try to access, that's how you get a hold of them. And that's a 24-hour phone line. After 5 o'clock, when people go home, we have a phone, we have a company that we use that take the messages and make sure that we get those messages the next day from by a group called Optum. So, and then substance use disorder treatment, we provide outpatient, intensive outpatient, perinatal residential, opioid treatment, and residential detox. Then over on the lower left-hand corner is a menu of our crisis services. So start with 988 suicide crisis line. Everybody knows 988 now. You know, 988 is like a national number. We contract with Buckaloo to operate the 988 center. And the wonderful thing about that phone line is, wonderful, I mean, that's a good word. I think the helpful thing about 988 is that's another 24/7 call number. And if you or you have a loved one or a client that needs to talk to 988 and all the lines are busy at the North Center that Buckaloo operates, you'll just be automatically transferred to one of the other 988 call centers in California. And they will take your call and help you sort through whatever you need to and get you connected if you need that. So it's 24/7. And also the data with 988 works. So like 95% of people that call 988 able to decrease the crisis and not go further. But we also have a mobile crisis response, 1-800-746-8181. So this mobile crisis response teams, we operate a call center 24/7. We were mandated by the state to initiate mobile crisis response 24/7, and we have done it. So it's wonderful. Yeah, thank you. It is. I'm really proud of my mobile crisis teams. It was a big lift. So the thing is that Sonoma County has really been doing mobile crisis for a long time. They started doing mobile crisis teams back in 2011. And the goal and vision was always to get to 24/7, but it's very, very hard to staff up a program like that 24/7, 365 days a year. So then when the state issued mandates, this is one of those unfunded mandates. It's like, okay, county, you need to be doing this and you have to do it by a certain date. And it forced counties to follow this model, which includes one of the most important things about mobile crisis response is we are not co-responding with police. So our mobile crisis teams, they go out, usually have a therapist and an alcohol and drug counselor, or a therapist and a peer provider, and they go out to support people who are having psychiatric crisis in the community. And then if there's a safety issue, yes, of course, then we involve the police. And we work really well with the Santa Rosa Police Department in response, as well as the sheriff, because all the unincorporated areas of Sonoma County. So this has been a great project and it's doing really well. So I'm glad to hear. Yeah. Well, okay, the kids, be aware that so we love our 24/7 mobile crisis. But the governor in January in his, I don't know, State of the Union or whatever, State of the State, he's proposing to change the mobile crisis benefit and not make it mandatory for counties, instead make it something optional. Now, you go, well, that doesn't sound so bad. But you know what happens with that? we don't get the same reimbursement
Yeah.
for going out. So right now, even though Mobile Crisis was an unfunded mandate, when we go out and provide the service and we do everything we're supposed to do to get to be in compliance with the benefit, we have a pretty good reimbursement on that when we go out.
Is that through Medical?
Yes, that's totally
Go
medical.
through all the steps you get.
Right. You have to, for Mobile Crisis, there's like 4 different things that have to be done in what they call an encounter. So if you meet all of those, we get a pretty good reimbursement. It's probably about 3,600 for every encounter. And so, if we go to optional, we're gonna get like 50% less of the cut. So instead of like an 85% reimbursement, we're gonna get 50. Yeah.
Yeah.
So,
You're saying call Gavin?
yes, call Gavin and say,
His wife's in the.
yeah, so I don't know, I don't talk to the governor, but he might be, a lot of counties, it was really hard to staff up 20%. It was really hard, okay? If we didn't have Measure O, and we also used BHSA money, but also Measure O, it's like, those funds really helped us staff up to be 24/7. But there are a lot of counties that have struggled with that, so that might be, I mean, I'm not making excuses for him, because. But that could be some of the pressure he's been, but I think.
He wants to be friendly.
Wouldn't it
Yeah.
now also, Medical got cut?
Yeah.
So they're getting less from the Fed.
Yeah.
And then the state has to backfill.
So-
Would be my thought.
That's right, so there's that too. Okay, so we have the crisis stabilization unit, you already asked about. The crisis stabilization unit it's a 16-bed facility, it's over at the lakes. And then the PUF, and then we have crisis resolution. So that's kind of the basics there. Okay, so now we're gonna move, yep,
The staffing for the mobile crisis response teams. Are these 8-hour shifts?
some of them, a lot of them are 10-hour shifts, so with mobile crisis, 10 hours,
Okay,
yeah.
so beyond 8 hours, they get time and a half.
There's things that we've worked out with HR around those extra 2 hours, yeah.
Meaning,
They refer to them as an alternative work schedule,
Right.
AWS.
Yeah.
And you can do like 4 10s, 3 12s.
Right.
And it's not an overtime type thing. It's called alternative work schedule.
We also have that in our crisis stabilization unit, similar to hospitals do that, we have 4 10s. Yeah,
and this is in the Santa Rosa area, you're familiar with the safe team that
Yes,
operates in Petaluma? Are you familiar with the debacle that happened down there? The debacle?
which one?
Yeah.
So we contract with In Response, we do co-response with Santa Rosa. And then we're also trying to develop a contract with the safe teams in South County, yeah. But they are, there's been some issues there because they don't have, licensed clinicians for those teams, and so there's some back and forth on that. But safe, what do you need to know, Don, about safe? Which debacle?
Tell us, don't speak up. Don't be afraid.
Well, there became an issue that when they were sleeping on a 12-hour shift, they had to be paid time and a half.
Oh,
And they weren't doing that. So there's a huge lawsuit right now where the team members of SAFE are suing the Petaluma People Services thing.
oh, no. I didn't know about that. Thank you for telling me, because we've been in some intense negotiations with SAFE lately, and the cities around really getting the contract straight because of the requirements for Medi-Cal for mobile crisis. They're very strict, and so I didn't know, we wouldn't pay people to sleep on the job. No,
Yeah, well, that's what Elise tried.
yeah,
She lost her job over it.
I want to talk to you more about that because it's not, okay, yes, it sounds. That's interesting, yeah, she's not there anymore and. Okay.
Let me, can I put on my other hat? On the oversight committee for Measure 107 that the board of supervisors appointed. And our job is to try to make sure that money is spent according to what the voters voted. So every quarter we get reports from the department, reports on how we're spending money. We are under attack by everybody to get money to Measure O. It is $30 million a year that we get. And of course, the first couple of years, we were trying to push the money out the door, get everybody out, you know, because having a reserve didn't have anyone involved. And we set up a fairly dependent, you know, agencies and programs that were dependent on our Measure O money. And the expansion of attack, cities, everybody else coming and saying, we want our money too.
Yeah.
Is putting a lot of pressure on Measure. We have only a few more years of it, and then it either will be renewed or ended. And that scares the heck out of all of us, because it is the slush fund of the county, in our opinion. It's not necessarily, and no one's made any noises yet from our board about whether or not we're meeting the voters' expectation. But when we get unfunded mandates and we reach into that pot and say, okay, we're gonna do global crisis. We paid billions of dollars last year and we're continuing to pay, and they're asking even more from the cities because, as you know, the cities got one-time monies from ARPA and PG&E and all that, and started these programs.
Yeah.
And now those funds are ending. So they're all coming back to the county. It's a tense moment, and I just want to point that out.
And to add to that, Gregory, too, is that Nolan, my boss, is like very concerned about the Measure O money. And also the fact that Measure O really supports some critical programs in our system, you know. Whether it's the crisis stabilization unit, the PUF, residential care facilities that a lot of our conservatees go to, which is all really expensive. And we actually had to dip into Measure O to fund some contracts with some facilities to place they're called Murphy conservatees. So Murphys are people who are conserved, they're going to be disabled from their mental illness, but they're also extremely violent. So then they need special placement. And so Nolan had to, we were like, we have to. So, okay, do something to Measure O. So anyway, it's an important funding stream, and his goal is to go out on a roadshow soon and start talking to communities about, hey, we need to extend Measure O and keep it going because of the kind of programs that it supports.
And we just gave out $10 million from Measure O in the past week.
Oh, the
Board
no.
of Supervisors. Yeah, the Board of Supervisors funded a lot of homeless programs with moderate to minor clients, which is kind of it's kind of extending your responsibility via Measure O.
Yeah.
And it's going to make it harder for us to keep that kind of like, oh, you're moderate to minor, you're over here in the, you know, the other system. Oh, you're severe and you're in our system, because we're funding people, agencies who are serving both.
Well, that was my question. You guys are gonna have homeless services as part of this?
Yes.
And does it have its own stream of money coming with it, or?
Yes and no. So one of the reasons why I was a big proponent of bringing homeless services to behavioral health was when Proposition 1 passed. And they changed the funding buckets in Proposition 1 to create a funding stream for homeless. And I'm like, I said, it was not Nolan, was it? It was Tina Rivera was the director. And I said, Tina, so maybe we should have homeless services should be over under us, so then we can manage these funds, and also the staff can be trained to use our electronic health record, they can be trained to do assessments and all that kind of stuff. So now it's happening. But they have lost a lot of their funding because of HUD and all the federal stuff. So hopefully that's not gonna last forever. We'll see. I don't know.
So question about the mobile crisis response. So I know you contract with in response, but for the other parts of the county.
So,
On their own.
so in response is a very cool model. So we contract with the city. So we provide the therapists from our mobile crisis teams and they go out on calls with system navigators and peer partners from Santa Rosa in response unit. And they go out and you see the bands going out there. Those are our people working on those. And then we're also trying to contract with SAFE down there.
But if there's operating.
We operate mobile crisis throughout the whole county. So our call center is 24/7. They get a call. If you're in Burnsville, we'll send a team out. They'll go out everywhere. They go out everywhere into all the unincorporated areas. When SAFE has a client that probably needs to be 5150, then we go down, our mobile crisis teams go down and support SAFE to do that. Yeah. So we're going down to how we help.
But it's evolving from a patchwork of separate
Yeah.
to a integrated collaborative.
Right, that's how we want it to be.
Yes.
Right.
So
So
my
it's
experience
common.
with SAFE has been, having armed police officers show up at my house. So I can't wait
Well,
for
see,
that to.
that's why this is when they changed when the state said, okay, you gotta do it this way. You can't run your calls through 911 anymore. You have to have your own call number. So that's why 800-746-8181 was a big deal because we had to stop using 911. Because for clients that are in crisis, most of them freak out when they see the police. Our clients experience a lot of stigma. Okay, so anyway, yeah. Okay.
Looking forward to South County getting.
One more quick comment. It isn't absolute that everybody in the country is setting up crisis lines that are not connected to the police departments. There are some police departments, and some of you who went to the conference that the department put on, who listened to someone trying to think Eureka or someplace where the police departments are doing a better job of interacting with clients, and they didn't set up a separate one. They just told the police, you gotta be better. And they came down and said, hey, look, we'd like to, train your people in the police department, so maybe you don't need that alternative, mobile system. That's quite a ways from where we're at right now.
Well, actually, that was my question for you is, you see somebody who's clearly mentally ill on the street and sometimes having trouble and the police will be there. Do they then know to call for backup? Do they usually do that? That would be my question.
Well, that depends on your community, Kathleen. So,
Okay.
like, if you're a federal
limits.
yeah, you can call SAFE or, and we have a pilot program with the community of Sebastopol. So Sebastopol wanted to set up SAFE teams, and we said, no, that's, you don't have that many issues, we don't have that many calls. So, but we want to support you. So we stationed a staff person from one of the homeless services programs from Heart and Soul. And that person is out there in the community, helping intervene with homeless people on the street. Because just because you're homeless on the street and you might be talking to yourself or whatever, that doesn't mean, that's not a call to mobile crisis. Mobile crisis is really people for help. So, yeah.
But I have to say, from a clinician point of view, in response makes a big difference bringing people to the emergency department. The clients seem to be more receptive to that, and the interaction between the emergency department staff and those people is a lot better.
Yeah.
Because police officers, that's not the primary role, and they don't have, in terms of interacting or questioning or getting some information prior to arrival. That's not what they would be doing. So, but the crisis people, we train, there's a purpose on, so we get a better report from them, and the handover is a lot smoother. So it makes a huge difference in terms of the quality of care that they get from the crisis points where they picked up forward to the delivery and the emergency plan. Since I have to say, I still spent a day or two in acute care, so I see it.
Yeah, it's good.
And like Healdsburg, the police department has hired the NFT on their staff.
Yes.
So we also partner with them, so when he needs backup, our request team's still up there.
Yeah, you can't be 24/7.
Right, he's not trying to.
No, I was right, no, but just someone said.
So Healdsburg, right, we invited,
Healdsburg has,
Hillsburg decided to use the police and therapist
yeah,
model, and it's okay. So,
So, but it still goes back to the purpose makes a difference in terms of the care. So we need to encourage that and support that because they make a huge difference in the quality of care that is fine.
totally.
It goes back to the no one doors, ladies and door.
Right.
Where do people interact with our system and how do they do it in Healdsburg as opposed to San Rosa, as opposed to Petaluma?
Yes, fine. Okay, let's move on now to the next slide, please.
Yes, ma'am. Yes, ma'am. I can see them now.
You can see it on.
Okay, well, I know everybody has the color copy. You have the slide, so it's this one, so this is it, so this is like a map of the behavioral health division. Okay, so the division is separated, we have 5 sections, okay? We have quality assurance and performance improvement section. And we have youth and family services, acute and forensics, adult services section, and you can see the adult services section was just a little bit bigger than some of the other ones. And then substance use disorder and recovery services section, okay?
And soon homeless will be.
Yes, this slide is gonna look a lot different July 1st. There'll be 6 sections. There's gonna be 6, there'll be 6 blocks there, okay? But we haven't moved yet, so
That's how
it's gonna look. Right. And then, so just a couple things. So up there in the gold box, division director, that's me. Then we have a medical director. His name is Michael Quash, and Sabta already mentioned him. She supports the medical director. I also have a special projects director. His name is Ricardo Goodridge. And he has been a blessing, has helped me quite a bit in the last year with all the special projects that we had, all these mandates coming from the state. With SB 43, care court, bridge housing, everything. I have a BHSA coordinator, that's Melissa Ladresh. You've met her numerous times, she's the one who comes and presents on Behavioral Health Services Act. She's gonna be coming Tuesday to present the integrated plan, the narrative of the integrated plan. And then cultural responsiveness, inclusion and training coordinator, that's Lisa Nozel. So those people also report to me. And, let's see. So you can pick any one of these, especially, so quality assurance and performance improvement section. That each one of these sections has a section manager, and then those programs report to that section manager. So our quality team, they're really the ones that monitor what we call the mental health plan, because we are behavioral health, we're a mental health plan. And they perform utilization review, quality improvement things. They audit and monitor charts. They want to make sure, basically their role is compliance. They want to make sure that we are complying with all the regulations from the Department of Healthcare Services. And that we're providing services the way we're supposed to. So they're also very much focused on making sure our services are timely, that we have access for everyone. Access, timeliness, and network adequacy. So network adequacy is a big deal in Medi-Cal because they, believe it or not, the state monitors all our zip codes or to see how many, the population in our zip codes. And then out of that population, what percentage of those people meet Medi-Cal, they are Medi-Cal eligible. And then are we providing services to those people? So they call that penetration rates. So they want to make sure that we have an adequate network to meet everyone's needs. Okay, so right now our NAC is doing okay. NAC is okay.
So what is okay?
So
I'm sorry, I sound like,
It's
I
true.
apologize, sorry.
Well,
That's what I'm saying to students, what is okay or what is good,
so that's why, I wanted to have, I suggested that Chris Marlowe come and do a presentation to all of you from Quappy. She could talk in more detail about all the things that Quappy is preoccupied with, the data and how they collect the data. So, according to the Medi-Cal requirements, our network adequacy we're okay with, adequacy right now. I don't know I don't know, off the top of my head, sorry. I think what we're more concerned with is things like timeliness, so. And when someone gets out of the hospital and they need a follow-up appointment in the clinic to see a psychiatrist, timeliness. Or the other data point with timeliness is, okay, I realized, oh my God, I really need to get an assessment, so I call Access to schedule an appointment. So timeliness gets measured once I talk to them about what I need, that I get an appointment to have an assessment within a certain amount of time, and I must get that. And we are meeting the timeliness. Where we get jammed is in, after the assessment is referring people to the right services, okay? So we.
And early on, you gave us reports on your vacancies in staff. And I assume that impacts what you're just talking about. When we were at 25% vacant.
Yeah.
It must have been very hard to be able to get anybody to get into appointments or get anybody into the system.
Absolutely.
We're down to.
We're at 8%. So we've gone from 28% staff vacancy rate, which is terrible, to 8%, which is amazing. So that was a unified plan. I mean, everybody working together with recruitment, interviewing and hiring. And then, hiring, you have to credential people, you have to train them, blah, blah, blah. It's a lot. So yeah, we're doing okay. We're doing, yes.
Now, the integrated plan. The integrated plan begins to measure some of the same things.
That Quappy
is. Yeah, that Quappy is. And so I expected, as we move forward, those kinds of percentages, those kinds of goals, our assessment of how well we're doing against the integrated plan will be similar to what Quappy has been doing.
Yeah, it should be, yeah. So some of the data that Melissa's pulled into the report, you'll see this when she presents. It doesn't surprise me, in terms of numbers and so on, yeah. And, especially with minority populations in Sonoma County, they're still extremely underserved. Okay, so.
We have to move in some for you, Jen.
Okay, so let me, so the little stars, these are things that went, like big things that, especially in 2025, that just want to highlight. So in youth and family services, we have staff at Valley of the Moon, we have staff at Juvenile Hall. But we also, we have the CAPE teams, so crisis assessment, prevention, education teams. So those are like, full crisis for high schoolers. And so the CAVE teams go out to all the high schools in Sonoma County and provide crisis assessment supports to those high schools. They also do a lot of groups, teaching youth mindfulness for anxiety. They do a lot of drug education groups and that sort of thing. So we beefed up CAVE last year. Then we also have a Latinx family therapy clinic that opened last spring. And that was the result of, again, the state saying, you've got your penetration rates into the Latino community are really poor. You guys got to get your act together. So we've had a couple work groups that we put together. And over time, especially in youth and family services, they have built up their staffing. They have many, many bilingual staff, all, whether they're professionals or office support staff. And then one of the managers created a Latinx staff support group for the bilingual staff. And then out of that, it grew into a clinical support group. And then they created this Latinx family therapy clinic. So I'm really proud of that. And then under acute and forensics, the mobile crisis teams, we already talked to you about that. SB 43, that's the other one. That's another one of those unfunded mandates where the state changed the legal definition of gravely disabled to include folks with substance use disorder issues that are, very grave. They're gravely disabled because of their SUD issues. So that we have launched SB 43. If anybody has any questions about SB 43, it's like, what is that? You can go to our website, and Ricardo Goodridge built out a beautiful website, informative website on SB 43. So you can find out everything that's going on with that. We're keeping tabs on if our conservatine numbers are going up, which we expect they will. And then if they go up, we're gonna need more Measure O1 Gregory for anyway, but we'll figure that out later. So then we had Careport Bridge Housing, that. Then last but not least, over under Substance Use Disorder Recovery Services is DMC ODS. So that stands for Drug Medical Organized Delivery System. So in the old days, when you had a drug or alcohol issue, you mainly got treatment because you got in trouble with the law. Okay. And but let's face it, drug and alcohol issues, that's a health problem. So fortunately, the state has changed some of the rules, and we implemented drug medical ODS. They went live in December 2024. So that means that we're creating a whole continuum of care to support you at whatever level you need. Do you need a group once a week? Do you need to go to detox? Do you need medical detox? Do you need like 30-day residential, whatever it is? So that's the drug medical organized delivery system is exactly that. It's a whole continuum, and we're in the process of building that. And it was very fortunate that opioid settlement funds kind of fell into our lap as we were launching DMC ODS, because we've been able to use opioid settlement funds to support some of the growth here, because this has been another place where we've really been growing. You can see we have all these programs: residential, outpatient, narcotic treatment, blah, blah, blah. Okay, last slide. So this is like little print too, and this is gonna change. So in July, this is gonna be different. I'm gonna have 6 sections, not 5. And also Behavioral Health Services Act. This is gonna look a lot different. So right now, what you have listed here is all the BHSA programs that we support right now. So the top 4, those are all our peer programs. Those are all our peer run programs. So there's the Wellness Center on there, Russian River Empowerment, Petaluma Peer Recovery, and Internet. So NAMI, we work with NAMI, National Association of Mentally Ill. Some of you know Mary Francis, she gets that going. Buckaloo, North Bay Suicide Prevention, that's the 988. Santa Rosa Junior College Peers, Latino Service Providers, College with Images. And then down at the bottom is the Transitional Housing, Sage Commons, Crossroads to Hope. So prior to Proposition 1, we were already funding housing projects for folks. People with behavioral health issues that had housing needs. And so the Sage Commons, Orchard Commons, and Caritas Homes, that's an example of some of the projects that we had funded. And then over on the right, just want to close with, we also have patient rights unit. So patient rights is, especially in California, the rights of people with mental health patients who are very well protected in California. So especially back in the 90s, there was a big movement to and that's the recovery, all the stuff around recovery, very important. So in particular, though, our patient rights folks, they're the ones that represent people at the 5250 hearings. They are the ones that go to the hospital. So once someone goes from CSU, they go to the PUF or they go to the hospital, our patient rights folks go to meet with them and sit in on the hearings. Do they still need to be hospitalized? Do they still need to have their rights, secluded, cloistered? Do they still, because when you are 5250, that's what happens after 5150. When you are put into inpatient care in a hospital in a locked setting, you are losing your rights. That's a very humiliating, stigmatizing kind of experience. But I have to say, our patient rights people are just so compassionate and caring. They go see all our patients in the hospitals and our PUF, and they support them through this process. They also did a really great educational piece. You can find this on the website, the SB 43. They did a great training for all of us on SB 43. They also look into potential rights violations. So there are a couple of times where I've heard, I'll get questions about stuff that might be going on in a facility, and I can call patient rights and say, hey, you keep an eye out for me. It's like, what's really going on over there? And what are the issues? So it helps to know. So that's a little bit, we have our contract is with Alameda Psychological Mental Health Association of Alameda. And they're excellent, really good. Okay, so that's good.
Before you do this, I just want to ask one question. You told us in the past, and we're very much aware of the kind of problem getting of the old HSA money by taking 30% out and putting it into housing.
Yeah.
So, and sometimes when I read behavioral health services, I have to interpret, say, is this MHSA money and where is it going? So are these the survivors of getting who will be going forward on July 1st with contracts? Or, I mean, how should I read this in terms of who's not guaranteed, but who's going to be going forward with programs? Are any of these vulnerable or still until June 30th? What is this piece?
Yeah, they're vulnerable.
Okay.
And the providers that are vulnerable, wrote them letters, let them know, they know, the writing on the wall. However, we have done our best to try to, so for instance, one of the categories that's going away is prevention, because prevention, the state decided, okay, that's public health's domain. So let's give them some of that prevention money, and behavioral health won't do that. So some of our prevention and early intervention programs will get renamed maybe into early intervention. We've done some of that to try to protect them. And right now, because it's a whole new plan, we've issued a RFP to the community to say, hey, these are the buckets of money, these are the kind of programs we want, and then providers submit their proposals to us. So hopefully, we're going to be able to keep Latino service providers, don't well, positive images, them. But the top four, those are peer centers, they're peer run, and they they will be most likely impacted, and they know this. So one of the things that we've done is, we're want to opt in. So this is gonna take me another 5 minutes to explain this. Is that okay?
Oh,
Is
absolutely.
that okay, Peterson?
That fits it up to most of our grades.
I'm sorry, okay, so. So another initiative that, and I think I've talked to the board about this before and, when, maybe in April or May, I'll do a more detailed presentation on Behavioral Health Connect. Okay, so that's like Behavioral Health Connect is our last mandate with Cal-Lane, okay, with all these years of transforming Medi-Cal. And so under Behavioral Health Connect, they want us to be implementing certain designated evidence-based practices in our systems. Well, we're already doing quite a few of them. We do assertive community treatment, we do a bunch of them. There's a couple of them that we don't do, and one of them is called Clubhouse Services. So Clubhouse Services is an evidence-based practice that uses peers to run the clubhouse. And if we opt into doing that, we can get reimbursed. We will get Medi-Cal reimbursement for operating clubhouse services. So right now, the money that we invest in the wellness center, and it's a good investment. The wellness center is amazing. We use the wellness center quite a bit.
Yeah.
But we don't get compensated. We don't get any kind of Medi-Cal compensation for all those services that get provided at the wellness center. Under Clubhouse, we can. And so I'm trying to go for maximum, revenue generation as much as I can to protect the system. So we are issuing an RFA for Clubhouse services in our adult system and we hopefully West County is going to submit some proposals for that. Will that make sense?
Yeah.
They're not,
Early
we're
on.
gonna take them, we're taking them out, and anybody who's been paying attention to the BHSA announcements about the RFP. RFP is request for proposal, and we're taking peer centers out of that and we moved them over to adult services. We want to use the clubhouse. I'm excited about that. I think that will, I just want to make it, want to maximize as much revenue as I can. So that's what's going on with it. Those four are probably going to change. It's hard, and they know that. They know.
And again, the homeless services. There's been lately over the last, I guess, 6 months, a real move to peer certified and support, folks who are capable of getting reimbursed from an account.
Yeah.
And I remember a couple of months ago, you said you were looking for some way of centralizing and/or having a cooperative billing system, or at least a process whereby agencies or staff working in agency could somehow get reimbursed through us. And it hasn't, as far as I can see, it hasn't gone very much there. Within the homeless coalition, Cristobal from COD said, Aliados Health and others will say, hey, look, we use these folks, we get reimbursed, we'll teach others how to do it. And I think that's, from my point of view, that's been measure of hope to a whole lot of the staff who are peer-based staff.
Yeah, absolutely. And that's an example of how complicated things are. So like COTS, Cristobal, they're doing ECM and CS. And like, you guys are like, what is that? That's like, okay, that's another one. So that's another, that's another place where, the system's complicated and it's an opportunity for us to, generate revenue actually with that, and instead of no revenue. Okay.
Okay.
Thank you, Peterson.
Welcome. Shall we wrap up and take a break? And thanks, Dan.
You're welcome.
I just want to say real quick that, I want to remind you guys that all the acronyms that are always thrown out there are behind on the last few pages of the minutes. There's 4 pages of acronyms for you to,
Familiarize yourself with.
At your
Take a
leisure.
break and take a 10-minute break. We run some parts of our.
Okay.
And so 10. We'll be back at 11:25.
I'm gonna have to, you know what? Because this money.
Okay.
I would rather stay here.
Thanks for coming. The conversation, but we have to continue. All right.
I mean, yeah, that was crazy.
Thank you, everyone. I'm so sorry I have to leave.
We are too.
Sorry, but it's late for lunch.
Thanks for coming. All right, we are going to go into item number 3 on our agenda. The bylaw. Okay, I'll leave that for Gregory, who is very much into the bylaws. To lead that conversation.
Well, I'm not sure we're gonna need as much time as we have on the agenda for obviously trying to alert people. So let me just tell you that there is something that I put over on the corner that looks like this. Well, I hope you all have one, if not, I'll try to help you do it. It's right out of our bylaws, and it's basically the section of our bylaws that says, here's what we as a board of supervisors expect you to do. So these 9, A through I
No, no.
are basically our job. It's what we're supposed to be doing from their point of view. It's why they appointed us. Now, there's one more that I would add, which relates to the integrated plan, because Prop 1 passed after this was on our bylaws. These bylaws responsibilities have been around for a long time. And when I first read them, I thought, gosh, some of them are really what we're doing right now, or what we're supposed to be doing, and we have plans for doing it. I'll point out 2 in particular. One is the annual report, which we have been doing for quite a few years. It's submitted an annual report to the Sonoma County Board of Supervisors on the needs and performance of the county's behavioral health system. Pretty clear. And pretty much what we do when we try to listen and try to find out what, programs are doing and where, gaps may exist. So that annual report is our vehicle for doing this, and it's expected by the Board of Supervisors. The other one that I think is, more general, but it probably relates a little to the integrated plan, and it's number C. Advise the Sonoma County Board of Supervisors and the local behavioral health director as to any aspect of the local behavioral health and substance use disorder programs. So again, these are kind of you're in charge marching orders, not that you're gonna dictate anything directly, but we're supposed to be giving our advice. Our advice is gold as far as the Board of Supervisors. Now, Kathleen was pointing out that her supervisor doesn't even know her. And we have that problem where a supervisor retires and they've appointed somebody and the new person doesn't really have a vehicle for talking to us. We have talked in the past as a board about setting up monthly meetings with our supervisor, having a way in which our supervisor can pick our brain and or we can tell them directly what it is we have discerned and want to recommend. Now, we have obviously Brown Act issues where we can't necessarily have every supervisor come before us or individuals, go for more than just 2 or 3 or 4, because as we get a quorum, we have to notice it. Now, one of the things that we're trying to work on that, and I just want to point out is Rebecca Hermosillo is the chair of the Board of Supervisors, having just been selected by our colleagues. The chair of the Board of Supervisors is on this board according to the board's appointment process. Every advisory board in the county has a member of the Board of Supervisors on it. And at the first meeting of the Board of Supervisors in January, they all decide who's representing them on each of the boards. And again, Rebecca chose to continue the process where the chair of the board is a member of the Behavioral Health Board. So on Tuesday, I expect her here. Okay, I wrote her a note about it and said, not only should you get to know your own appointees, but you should come and be a part of this board. So we'll see.
I mean, other counties, there'll be the board members sitting with,
I've gone
with the
to
commission.
Teresa's meetings. I often hear from other boards around the state about active participation of the members of the Board of Supervisors, Contra, Alameda, some of the, so.
During her tenure as chair of the board, did Linda Hopkins ever come sit in on any meeting?
Once that I remember.
She came in, Gurnville, yeah, but she wasn't there for the whole meeting.
Yeah.
Yeah.
So, but could Rebecca send one of her staff, like her chief of staff, to represent her?
There is another pattern of that, and that's the homeless coalition.
Yeah,
Chris Kersey is the person who's on the coalition by appointment of, the Board of Supervisors. And when he can't be there, he sends his staff. So, yes, is the answer. Rebecca could do that. I'm hoping that she'll choose to come herself, but they're busy folks and they've got 68 different advisory commissions.
Right, that's something.
Yeah.
So I'm in District 2, and I see David Rabbit once in a while at the dog park, out of the market. But, this issue you're bringing up there is really critical to be part of this board, because if what we're talking about is just staying within the confines of this room and within ourselves, then what's the point, you're not affecting each other. For me, it's educational, but I enjoy it, I'm learning so much. But I asked Dave, I said, we're just watching our dogs, going, hey, Dave, we're kind of bored, enjoy it, thank you. But how exactly, I'm not clear, because we got people from the community coming in and talking to us, and how exactly do we get that information up to you? And look at he goes, that's a really good question. I don't know. He goes, you could, he started thinking, well, you could email me or my clerk or something like that. He didn't have an answer for that. David Rabbit, and I have no problem with David Rabbit. And again, I'm kind of like an outsider inside the board, but he didn't really know. He didn't really know. And he appointed me, bought me a beer, I applied. We had a beer, you met me, and I thought, okay, I'll recommend you for the board. But he does not know, it's not right there at the tip of his tongue, how the work that I'm doing and that we're doing is going to affect any change, and that how that information can flow upstream to the supervisor. And that, so I think.
Who it was one of our reps, used to write a summary of the meeting and send it and email it to District 5 staff.
maybe was it Kathy Smith?
No, it was,
Because one of the Reynolds,
Randy, Michael Reynolds.
Oh, my God.
Michael.
And I thought, oh yeah, I'll do that.
Yeah.
But that is a way for them to get the information of what we're talking about. Is to email and update.
Yeah. But our minutes are available. I mean,
Right, that's true.
there are other ways.
That's true.
If I were in your position, if I were a David, I'd have a better answer to why, how you should report to me. But every one of them has said to me, we really want to hear from you. It's like, we really want to know what your concerns are. But they don't have and here's my appointment calendar, here's the way in which we'll do it. So we're in a real quandary, because the issues are so important. When they are, if you watch the last 20 minutes of the Board of Supervisors meeting last week, in which all the agencies who got money from Measure O or HAP were coming to them saying, thank you for this life-saving money. I was the last one to speak. And when I came up, I said, hi, remember me? I'm the guy you appointed to these funding sources and oversight committees, and we aren't gonna have any more money. And you're gonna be making really tough decisions. And if you could, a pin drop it was, on the room. And it's like, I concluded with, we're gonna be doing our best to give you the best recommendations out of the advisory committees. But at the end of it, Chris Kersey said, oh God, we have a birthday party for all these money, in other words, we're having this cake and light candles and stuff for this celebration of us giving out money. and you blow out the candles. And I know, yeah, so then Rebecca chimes in and says, yeah, not only did he blow out the candles, he threw the cake on the ground. And then they went into a really good discussion, all of them saying, but he's right. And we're not gonna have very much money, and we're gonna have to make really tough decisions. And yes, we gotta go to the state and get more money. And yes, we gotta figure out a way of figuring out who's doing a good job and can make it, and who we wanna just keep in business till they get to that point. So they're.
I want cake on their face.
Yeah, exactly, yeah. So I think the time is right for us to be able to do what we're gonna do, which is come to some conclusion over what we think the system is and communicate that to them, because they're gonna be going through the hardest job and the hardest time they've ever had. This is not gonna be fun for any of them, but they're gonna need to have some advice from people who aren't wanting money from them. You know, the reason we have these advisory committees is that we're supposed to be unconflicted. We're supposed to be giving the view from how we see it without any personal conflict.
Can you like briefly, concisely tell me, why is upcoming the hardest time that they've seen? What is it,
There's
the
two
federal?
hundred and $50 million in her department, I mean, which may not be there
Because of federal.
because of Trump. Okay,
Medical.
that's serious. That's shaking the heck out of everybody.
Some of it is other money too.
Yeah.
But with H1, whatever it is.
HR.
HR1. For instance, so that's gonna leave about 11,000 people in Sonoma County without Medi-Cal coverage. So when they need medical care, where are they gonna go? They're gonna go to the emergency room. They're not, it's like, that's the dismantling of the Affordable Care Act, basically. That's one of the ways it's in it. So it puts an incredible burden on everybody. So even if those folks some people come to our clinic to see a psychiatrist, they'll get a bill, but then they go to the pharmacy and they're not gonna be able to get the meds because it's like, yeah, the meds are very expensive. It's just the tip of the iceberg.
And most of the other, there's a lot of agencies, a lot of contracted services that braid funding from, one source and another. They put it together from local and state. The state is just as dire in its budget crisis right now. It's just not, it's not going beyond it like Trump is saying, not only am I not gonna give you money, but you can't do a program like you've designed. The state is leaving our program designs alone, being caught in if we do fund programs that do housing first, for instance, then we're not gonna get any money as a state. So Gavin's into the same sort of like, what are you doing? Analysis of what Trump is. But if we start getting both state money and federal money, and we have to operate entirely on county money, it's Measure O, it's Measure I, it's maybe opioid settlement, but it's nothing else. And that's gonna make it really hard for agencies and staff of the department to maintain the service. So how we get from here to wherever we get to, a lot of people are saying, well, we'll just get rid of Trump. Somehow the 2026.
Not till 2020.
Yeah, or 2028. I mean, it's like, so the next 4 years, I think are gonna be the most wrenching, terrible, how do I keep my hopes up? How do I provide services time in America's history? And I think Sonoma County is gonna be the poster child for it, because we've set good programs up using one-time funds and, good, smart decision-making. But whether we like it or not, it's gonna unravel.
Chris Rogers yesterday framed things as we're like planning state budgeting for the collapse of the California healthcare system as we know it.
Yeah.
So,
I should just make a point of order.
Sure.
You're on bylaws discussion.
That's true.
This is a public meeting, so you have to stay on agenda.
Thank you.
Okay.
That's what I'm here for.
So.
Good, thanks for that.
So.
I'm trying to get to.
Okay.
So back to this, I recommend that everyone of us memorize these 9 things that we have to do. And we look at the bylaws as our marching orders of the students. How we communicate this to the Board of Supervisors is also, I think, a good, within this topic, because in order to do these bylaws, in order to do these things, I think we have to put together some strategies for how we communicate with our own appointment focus, our supervisor. That's really all I was hoping this committee, this discussion would cover.
So a point of clarification, when we're like reviewing and evaluating the community's behavioral health needs, we're looking at serious mental illness and for the Medi-Cal population. So it's not the whole community. I think that's something that.
I think we have to take, Jan's definition and description of the department, local behavioral health and substance use disorder programs are her department programs.
And
It's
that's
not,
our.
that's our responsibility. It isn't, I would love to have end homeless programs and, Medi-Cal and SNAP and lots of
Or
other things.
people who aren't on Medi-Cal who have anxiety and depression.
Yeah, exactly. It's like, I look at the larger picture and think we ought to comment on that. And if I think that Gore needs to know about something that's happening outside of the behavioral health, I'll tell him. But this, if we were to make a recommendation, which is, that's the other thing, our bylaws and our processes confirm that if we, in a quorum of our board, make a recommendation, which is called substantial recommendation, that says, we want you to do this, then unlike a lot of other advisory committees, the board can't ignore it. Okay, the board has to respond saying, we heard you, here's what we're doing. That's the only power we really have, is to hold them accountable for responding. We can send them any number of recommendations, and if we were the Park and Rec Department or, the Open Space District or even general plan of the county, those advisory committees don't have that requirement that they respond. So I want to test it. I want us to be able to come up with whatever conclusions we come up with before we get to, the point. And it doesn't stop with our fiscal year. This is something that if next fall we figure out there's something, if we make a recommendation, we're supposed to be listened to. And as long as they seem to want to do that, I'll stay on this board. If we start making recommendations and they decide, screw you, we're not going to listen to you, and it'll be a real test of whether or not I believe we're doing anything. Just like when you talk, Kathleen, about what am I doing on this board? What's it all about? I believe strongly, I've talked to every one of the board of supervisors. I think they believe in us.
On point H of this section, it says review and assess the impact of realignment of services from the state to the county on services delivered to clients on the local community. How do we do that?
Well, that's my first test, because as you know, I put on the agenda for next Tuesday a request that we've talked about, which is to ask the board to lobby the state to get us more money under the kind of thing called realignment, where they gave the counties money for things, for responsibilities they had asked them to take on. Those two realignments in the past are helping us continue to do the unfunded but mandates of the past. So we could ask for another realignment, and that's what I'm asking us at the board meeting on Tuesday to make a recommendation for.
Yes, Jenny, wanted to say something?
So just to add to what Greg was saying, so it was like, people like, what is realignment? What is that? So in 1991, the state decided through legal regulatory activity to realign services from the state to counties. So they said, okay, counties, you develop your own mental health plans. We're going to give you regulation. We're going to give you like an outline of what you have to do, but you guys are in charge of doing your services. So, and we're going to give you, we're going to give you 1990. We're going to give you money for that. That's called 1991 realignment, and it's based on some kind, a tax on something. I don't know if it's vehicle taxes or what it is, but so it's a Lanterman-Petra Short Act. So LPS, it's all short oil, Lanterman-Petra Short Oil Act money. And so then in 2011, the state created 2011 realignment. That is supposed to, that's another funding stream, and it's more geared towards kind of safety in communities and so on. So we have 91 realignment and we have 2011 realignment funds, and that, so technically 91 realignment is supposed to help us pay for hospitalizations, for sending conservatees off to long-term locked care, for all these kind of like really essential mental health services. And also it's supposed to fund our ability to build out our outpatient clinics and our community services. But it's not enough, clearly, so we need it. So Proposition 1, which previously was Proposition 60, the previous MHSA proposition in 2004. MHSA came along in 2004 and said, okay, realignment isn't giving us everything we need. We need to support our mental health communities with MHSA. So there's that. So there's realignment, and then it was 2011 realignment, but we're in like 2026 and we have much more serious behavioral health needs in the community that require, we need more money. Yeah, we just need more money. I think I need to send to the, I'll send this to SAPTA, just remind me. Cal Mesa did a report, they had Rand company do an evaluation, and they released a report this last year of that our adult system is not getting the funding that it needs to really provide the services that our adult, seriously mentally ill adult clients need. And it's like, it's true. We need, and our adult system, we do the best we can. We have case management, we have psychiatrists to provide services, we have board and cares. We try to create a continuum, but there's a lot of pockets, there's still a lot of pockets of need out there. And so I'm gonna remember the RAND report and send it to you guys, because it's really sobering.
What's interesting to me
Because
is
it's
they
data.
do the same thing to the school system.
Yeah.
And it's not the only reason the school system is broke, but it is one reason they give them all these unfunded mandates. And especially around special ed and stuff like that, but others too. And then they don't fund them. And so it puts the school system in a tough situation. Now, there are things they could do that would help, and they're just starting to look at them, and they should have looked at them before. But that unfunded mandate thing is just like so common.
Yeah, okay, so let's look at.
But it is, it's a reality.
But I'm glad you brought that up, Pearson, because it is what the board expects us to do when we need to
Right.
do it. And two more things. The board of supervisors themselves talked about asking for more realignment 2 weeks ago. So they didn't take any action, they just sort of mumbled it while they were moaning over the fact that they didn't have any money. And when Chris Rogers and Mike McGuire showed up in the library a week ago, I asked the question. First question out of anybody's mouth was, hey, what's about realignment? What about an additional chunk for unfunded mandates? Now, I was disappointed because Chris Rogers then stood up there and said, oh, we always pay for anything we give you. It's a requirement of us, you know. Yeah, I'm sure, Chris, let me show you the 5 things you've asked us to do that you didn't pay for.
Yeah.
Well, the devil's in the details, you know,
Exactly.
that's what happens. Like,
And then Mike
what's the
McGuire,
details?
Mike McGuire came in right after him and said, hey, Gregory, we want to work with Sonoma County. So, you know, I think we've got them half interested in doing something for us, even if it doesn't pass the whole Senate or Assembly. And we certainly got the Board of Supervisors who are primed for taking our recommendation.
Okay, so let's look at number D on this. It says review and approve the procedures used to ensure citizens and professional involvement at all stages of the planning process.
Okay, where are you?
That is
Oh, okay.
I can dog. donkey.
Can I speak to that a little bit? Because I'm gonna do the training later today that covers that piece. This agency has to include 29 different stakeholder categories within their planning processes for the Integrated Behavioral Health Services Act plans. And I'll go through what their requirements are and what your role is.
Okay, all right, so I'll get answers a little later.
It's a big question.
Ask a specific question about it, just since I won't be here this afternoon completely, and does part of letter D include like the days and times in which this board meets?
Yeah, sure.
Great, thank you.
Okay, having touched on letter D.
Yeah.
Let's look at letter G.
Yeah, speak to this one a little bit too.
Oh, okay.
Have we ever sent such a report?
For the,
So there,
go ahead.
Okay, yeah, a couple things about performance outcome data. You were supposed to send a survey every year to what's called the California Behavioral Health Planning Council. That's not my group. It's a state agency that advises the Department of Healthcare Services and the legislature. And over the last few years, their surveys haven't asked for anything regarding performance outcome data. So if you haven't done it, you're okay, because they're not very focused, but I think they're gonna become more and more focused, and I've been advocating that these improve. And also the state never fulfilled their duties 25 years ago when they should have put standardized performance outcome measures in place. So that's in process right now, and over the next year and a half, 2 years, we'll start seeing more standardized reporting throughout the state on measures related to behavioral health, like reducing arrests and incarceration for people that are within your services, increased attendance for children and youth who receive services or other measures related to children and youth. What else? Reduced hospitalizations, reduced homelessness, increased employment. So those are the ones that probably will be put in place, and there's a lot more. There's a ton of stuff that they're gonna want reporting on. A lot of it's already reported, but they'll add some things.
And many of those questions and many of that data is in our integrated plan as goals to reduce or increase our rates compared to the state, and to be able to tell them how we're doing it. I saw when I first read the Prop 1 thing, a heavy emphasis on new data and data collection and data analysis.
Right, and the state's trying to just look at sources that are already out there. But if you want to really hone in on the sources related to what the Behavioral Health Agency provides and what is the impact on the people served, then that's the area that this board should be focused. That's a performance outcome. It's not just performance, like something exists.
Yeah.
But it's not just access, is that, do you have that service? It's what are the outcomes for people?
Impact outcomes.
Right.
Yeah. So there's lots of good stuff we could be talking about and reporting on.
It's a little overwhelming.
Yeah, it would be good to know that, what those are. So we have performance outcomes that we have to also monitor in, the mental health plan. So HEDIS measures they're called, there's lots of different ones. So, and the integrated plan also is covering some of that stuff too. So, yeah. Data.
Data.
Okay, well, thank you for listening and for considering.
But did we talk about A? I think we went into others, but we didn't mention A.
Can I comment on A? You have part of what's in California law here, but there's a word missing. There's actually, this is kind of a summary of California law for your duties. And I'll go through this later this afternoon, but it should say public community's public behavioral health needs.
Um,
And that word's not there. So-
Okay, good.
Oh,
Wanted to
this
mention
public,
that.
okay. I put something in this language, just to see the way back when. We see.
In some communities, we've seen the boards advise the board of supervisors directly, if it's not something that's within the services of the behavioral health agency, but it's something impacting the behavioral health of the community, like sometimes it's like a bridge that people are attempting suicide. So what can we do to put something structural to stop that? Then you would advise directly to the board of supervisors. Usually you're advising to the behavioral health agency, but you know, you have a good example here of with realignment, advising the board of supervisors to advocate for more
money.
right.
And not just,
heard that.
not just the money, but yeah, but what impact are we going to have when we get the money? And if we don't have it, what will the impact be in the community and the quality of care or life of the people who really need this service? This is also very crucial.
And that's really what's behind Chris Kersey's ambition to be able to take Measure O on the road. And take our department as a whole on the road and basically say, we're worth it, we do a good job, you guys know it, and we need more money from you. To be able to get the renewal of Measure O at least solidly off the ground. If we can't prove that we're doing good work with the public money, then there's gonna be few people who will support our continuation.
I know we got it, there was a good, percentage of the communities that voted for it, but if we can show value for what they're collecting, then it will be an issue for them. Yes, Jan.
But would it be worthwhile for someone to come and present to this board the highlights of Measure O? Like,
Well, that would be great.
Yeah.
not if people go to a Measure O meeting, cause that, but if someone from Nolan's team would come and do a presentation, maybe Nolan could do it.
Yep.
The highlights for people to see, hey, guess what? You wanna know where your the Measure O money is going, to see just how valuable Measure O is and what it does.
I think he probably look at it as a good preview, well, a
Yeah.
good preview of what he's gonna tell the community.
Yes, I mean,
And
this is a
This is a
receptive.
receptive audience,
Yeah.
it's gonna, I mean, we'll ask the best questions we can, but hopefully we can help him understand where the community is coming from.
Yeah.
And take to the community his message. So yeah, I totally support that.
Yeah, okay, good. Well, that will be part of what you're asking about. All right. Okay, guys, it's 12 o'clock. And we will say this is lunchtime. We have half an hour for lunch. And let these people have to just. She talking and me getting tired of just talking.
Thank you. Yeah, thanks for inviting me. I think Gregory, I should thank, he invited me to come today, so I really appreciate the opportunity. I'll be talking about the Brown Act, which is California's open meeting law for local boards and commissions, and your advisory board. Within the Brown Act, they call you a legislative body. And since you do advisory work, you're in a special category now within the Brown Act. The Brown Act is a big document. It's California law, and it's 51 pages when I kind of compiled it from the internet. It's a lot, and part of it doesn't apply to you and part of it does, so it's very confusing if you look at that 51-page document and you don't know specifically what sections apply to you. So this is a kind of a complicated time for the Brown Act. During the pandemic, a lot of boards and commissions, really got used to using teleconferencing. There were allowances so that teleconferencing could be done without having any physical location posted on your agendas at that time. And when the emergency orders ended, and the teleconferencing allowances ended, a lot of boards and commissions wanted to continue to have that ability. So we have a change as of January 1st that allows more allowances. But there's a lot of different stipulations to that, a lot of different requirements and different ways to do teleconferencing. So a lot of this training, I'll talk about all those, but if you find it confusing, it is because it is confusing. So I'll just review with you what's there and what the changes have been. And I know some of you don't know the Brown Act, so I'm just gonna go through the Brown Act basics as well. All right, so we'll talk about the Brown Act basics and then the teleconferencing rules that have been in place for a long time, and teleconferencing alternative rules that are new or adjusted, and then frequently asked questions. As I mentioned, the Brown Act applies to advisory boards. And it's so that the meetings of public bodies are open and public. Any action taken in violation of an open meeting law may be voided. So if you vote on something and you haven't been within the Brown Act with something concerning whatever you voted on, that could be voided. A meeting is any gathering of a majority of the numbers. And we call a majority a quorum. A majority is more than half. Okay. And so we don't want to see a quorum outside of a posted meeting. This meeting today was posted. I looked on the internet and found it. I could, see that it was there. I'll talk about what the posting requirements are. But a meeting, we put that term in quotes because it's any time a quorum comes together and discusses something. So we don't want you on email discussing a topic that could become a quorum of you talking about it, or by chat, or on social media. Or if you're maybe at a conference within the county that's not behavioral health, we don't want you all sitting together at a table together. Doesn't look good, and you're probably going to be talking about behavioral health. So just try to stay away from any type of quorum outside of the meeting. Okay. Who is covered? Well, we talked about that. You are called a legislative body within the Brown Act, and specifically you're an advisory body. If you have any committees that meet regularly, those are called standing committees, and they're subject to all the Brown Act rules as well. Do you have any standing committees right now?
We have two.
You have two.
Executive committee and a committee we set up called the Annual Report Integrated Plan Subcommittee, which is a standing committee.
Okay, all right, so they meet regularly. All right, so the quorum applies to them, so that would be a majority of that standing committee.
Right.
You are, is a quorum, so you have to abide by the Brown Act. Yeah.
An ad hoc committee, is subject to weekly orders.
That's what I'm on now. I just flip to that, yeah. It's a good timing.
The quorum would be a quorum of the committee members.
Yes.
Right.
Okay, so if there's 4 committee members. We have
Would be three is a quorum. So who is not covered is on this slide. So what some people call ad hoc advisory or ad hoc committees, sometimes they're called work groups, that they come together just for a short time. It's less than a quorum. That's okay. You can do that. Maybe maybe you have something you want to research more, maybe learn about more in terms of some of the gaps and barriers for school-based services. you'd be able to do that with an ad hoc committee as long as it's short term. You might even want to put it on a piece of paper, what are the objectives of this ad hoc? What's your timeline? Who's on the committee? And then, it can be short term and you're fine. People can talk to each other outside of meetings. You can talk to each other, individuals can talk, as long as it's not a quorum, it's okay. And you can come together by email just to decide on the organizational things. Maybe Sabta might put out a message saying, does this date work for you, or something like that, things like that. Just organizational stuff is okay. All right, and then most nonprofit organizations are not subject to the Brown Act. And then state government agencies, they have a different open meeting act. It's called the Bagley-Keene. Any documents that are shared with the majority of your members should be distributed and posted without delay. So the public should see if it's in the subject matter of behavioral health, they can see what's been shared with the majority. So sometimes between meetings, there might be documents that are shared that could become part of your meeting packet. That would be one way to share with the public. Or just materials that are shared during your meetings, those should be also provided. Agendas, they need to be posted on the agency website and at the physical meeting location, freely accessible, so that the public knows where to go. They should be posted 72 hours in advance for your regular meetings, 24 hours in advance of special meetings. Today's considered a special meeting because it's outside of your normal schedule and time. So if it is a special meeting, if media wanted to be informed about your meetings, then you need to inform them about your special meetings. And then agendas should include the opportunity for the public to address the board or commission on any item of interest. So we'll get into more about public comment, because public comment needs to happen for all the agenda items as well. But we want to make sure that they have the opportunity to talk about things that aren't on your agenda as well. So there needs to be that opportunity. And then the things that you discuss should be items on your posted agenda. So stay on your agenda. Like I said earlier today, so it's good for all of you to stay on the agenda just to get through your meeting. But it's also, it's law that you stay on your agenda.
It seems like that could be a little gray. I mean,
We're not great though, we do it in this category historically.
Yeah.
We're not great, we deviate.
We deviate, I have to admit, we deviate quite a lot.
We deviate.
Right, so we have to stick to the agenda. Sometimes the discussion can get interesting and then we get out of it. And then to the point we want to move a motion when there was not part of the agenda. So we need to really stick to that.
Right. Right, if there are things that, come up and it sounds like you have kind of a nature to go off topic. It's just make notes to get back to that, you're gonna keep meeting, you can keep, put it on an agenda.
Right.
And then the public knows about that, you're gonna be discussing that issue.
And I'm sorry, I wanna say that and I don't like it, that,
Okay,
I don't like that we have to stick to the agenda. But I say that we shouldn't stick to the agenda. I just want to clear that.
Right.
Not because I want to be. Because I have to be.
And for those of us who have long histories of going to meetings where everything on the agenda was already discussed and ready to be decided without any discussion, I really appreciate, Becky's point of view, because as a member of the public, I don't want anything to be a surprise. you know, that a board takes an action on. If they're gonna talk about something, especially if they're gonna make a decision on something, I want prior notice. So that I can understand what they're talking about and then be able to add comment. And I can't do that if everybody deviates at any one moment and gets close to a decision in the discussion.
I understand that with an action item, but conversation, you know what I mean, sometimes flows and is valuable conversation and to limit it to, oh, well, it's, you know, a little off topic. It's very confining in some ways. I don't know, to me, but, and the public is invited and can hear, and it'll be in the minutes maybe. So I don't get why it has to be quite that rigid, but maybe that's just me. I'm used to a nonprofit.
Right, yeah, it's very different than a nonprofit board, because I run a nonprofit too. And yeah, so this, yeah, it's California law. So you all are, you're advising over the largest program in health and human services. This is, I don't know how many.
Actually, that's
millions of dollars.
Yeah. I'm on a community corrections partnership, so that's another group that's Brown Act. We have to follow the Brown Act rules and they're like, really?
They do.
You would not like that one, Kathleen. Just probation, chief of probation is the chair of that. and She's like,
Because an action could affect, you know, but for conversation, that's a whole, to me, it's a.
I feel the hand.
Yeah, what about public meeting? So people come in from the
Yeah.
public, and we're supposed to receive
right,
public input to the
Right.
board, and they want to talk about something that isn't on our agenda, they want to inform us of something,
Right.
so what do you do with
Yeah,
that?
yeah, they can do that, but you need to have it on the agenda for any, usually people will put public comment for any item not on the agenda. They'll have a period of time for the
Right.
public to comment on those items that are their own concerns that aren't on the agenda that day. And then your board members can decide, is this something we really want to look into and put it on a future agenda or do some other things to, you know, learn more about it. So public comment was what I was just about to talk about. So public comment should be before or during agenda items. You can put it after as well if you want to, but it has to, you have to give the public a chance before or during, okay? And then recording is okay, as long as it's not disrupting the meeting. Removal of individuals, this was part of the recent update. I think there was already some wording to remove people, but there's more wording to remove people from meetings if they're disruptive. And that requires that the chair or whoever is presiding over the meeting warns that person, and then if they don't stop their disruptive behavior, they could be removed.
And that's easy if they're on Zoom.
It's, oh, right, it's not so easy in person. Yeah, physically, it's not easy in person. No.
That's fun.
Sign in or identification is not required. And that's something you should put on your sign-in sheet to make sure people know that it's not required. They can be anonymous when they give public comment as well. And I think sometimes if they've, you know, specifically they're commenting on the services, they won't want to give their names sometimes. And then translation, if an individual needs translation for the public comment, they should get at least twice the allotted time for public comment.
With the translation, if the person who is speaking from the public does not identify or does not let us know beforehand, we don't.
Yeah.
We are not like prepared to do translation on the spot. How does that work? Then we can complain that they will not given the opportunity for translation.
Right,
should
yeah.
we be?
That could be something on your website and on the agenda. There could be information so people know that they need to, like, maybe a week in advance, notify SOPTA that they need translation. That's,
Can they bring a translator or is that?
yeah, they could bring a translator. Yeah, I think that's usually what happens.
Okay, because I was like, I would wait for someone to want to speak and hold back because we can provide translation.
This is about minutes and about public comment. Are we allowed to identify the public commenter? Or do we have to include public comment in the minutes?
No, you don't have to
Oh, okay.
include the public comment in the minutes.
Okay.
You can, but you don't have
And if
to.
we do, is it okay to put them, if they've signed in, it's okay to put them in?
Yeah, if they give you their name,
Okay.
then that's okay.
It's in the recording as well, so.
Yeah, that's true.
Do you post the recordings?
Mhm.
Oh, okay. Yeah, you're not required to post those, but
Oh, okay.
unless, I don't know, sometimes counties have additional rules, but.
It's just a practice, I don't think it's just a practice.
Okay, that's good.
Your comment up there, or in the earlier slide about before or during, I have a point of view that unless I hear what it is they're gonna vote, I don't know what to comment on. So, and during is very consistent with my spirit, but before, I've seen people say, okay, and the only thing you have on is some cryptic little thing on the agenda about what it is that we're talking about, and then asking me or anybody from the public to comment on it before we've even heard the discussion seems not very functional. So I'm for the during, not the before.
And there's reasons to do it before if you're having difficulty getting through your meeting. If you allow the public to provide their comment before, then it's more limited. They're not deciding or thinking about what they just heard and then on the spot giving their impression of it. So the agenda again was posted three days in advance, right? At least. And these are probably topics on your agendas that you've been talking about maybe for months before you vote on.
Yeah.
If you're gonna vote on a recommendation, you've been talking probably for a while. So there's been public comment probably maybe during that.
If it's a
as
topic
well.
that they have heard from us before,
Right.
or especially if there's a staff report on the agenda, because the homeless coalition, for instance, has exhaustive staff reports that you can read, so you know exactly what they're gonna be talking about. So all I'm saying is, you gotta respect the public's need to understand it before
That's true.
you ask them to comment.
And remember, you're gonna keep meeting, so they continue to have that opportunity, meeting to meeting as well. Sometimes it can be very difficult when the behavioral health director gives their update, if then it's open, because they've just given you an update maybe on 10 different items, and that opens up a lot of public comment. So in some counties, it just doesn't work. If it's a large county with a lot of people that do participate in the public, before works, but not during.
We have had, in the past, where we have had quite a bit of, public comment. Our meeting used to be better attended than it is now, to the point that we have to move from when we normally having to meet one of the churches to. And public comment was huge, like 12 people giving public comment, and they come prepared, have the script already prepared and line up and speak. So we have had it big ways, so it's not like something that's one experience since I've been around for a few years, I've seen it.
And the chair can, if you have a lot of people that come to a meeting, say there's a hot topic that people are very concerned about, they come in, maybe it's a community group that's brought 50 people. It's good for the chair before the meeting to talk to them and say, it would work well for us if you had one like leader give your statement and all of you can stand. You know, you all stand together, give that statement, and that way we know that it's from this group instead of having 50 people come through with public comment.
I have to say that most times what I have seen is when there's a proposed cut in some service and those who've been potentially affected or the loved one, they show up. Because they want to express how it's going to impact them and have seen.
Right. All right, so we'll go to the next slide. All right, so agendas should be posted at all for teleconferencing. This is teleconferencing. This has been in place in the Brown Act for a number of years, long time before the pandemic. You can do teleconferencing as long as the physical address of each teleconference location is on the agenda, and each of those physical locations is accessible and open to the public, so the public can participate. And so that works well sometimes for large counties where they'll have 2 actual meeting rooms in different parts of the county and they'll have it connected by Zoom. And then sometimes individual members will use that. Maybe they're staying in a hotel, you know, several hours away. But they still have to post that agenda outside their hotel room. And they need to allow access if anybody wants to come in and participate in the meeting. Okay, so it depends on the person. Most people don't want to do that. So I'll talk about some of
On that.
Okay.
See, because I'm just like, I don't know, it's a confession, but I have participated in meetings outside of the country and out, and they're physically out.
Okay.
So what is required? What am I required? There's nobody there, so.
You have to put your address on the agenda.
On the agenda.
Yes, so they need to know physically where you are, and you still need to post it
That's what I'm
outside.
saying.
Yeah, so whoever in another country.
We're gonna come and check. Cause we're not traveling.
She's coming.
You like to hike in the Caribbean, I'm coming with you. And I'll make sure you are. Yeah.
Thanks for a treat.
Yeah, you're gonna,
That's a good one.
yeah, but when you tune in from home,
Right.
that's different. You don't have to post your home address.
I'll give you some, this is basic teleconferencing, and the answer is you have to allow the public with this part of the Brown Act, but I'm gonna get into some alternative. So with this part of the Brown Act that I'm going over right now, you have to post, you have to allow the public to come in from their own home if that's where you're connecting remotely. But I'll get into some alternatives.
That's crazy.
Okay?
Yeah,
So since the general public can walk into your house and be allowed in.
Right, so it really detours, I mean, it keeps people away from that. Yeah, so
they can just go in online and give their testimony or respond to what's being said.
And
Yes,
also,
well, the public can do teleconferencing. This only applies to the members.
Remember, yeah.
but then the public would have your personal information.
Why do they have to know your home address?
Because you're a public meeting place when you do that.
You decide, yeah, it's your choice. If you want to attend by teleconference through this method.
You have to post it up
Right,
front.
but I'll give you some other methods.
And give out your address to everybody, to the public.
There was somebody,
Oh, great.
in San Joaquin County who, she did post her, this was during the pandemic. She posted her address, and, opened up her front yard. And people from the community came to the meeting in her front, I mean, they all had their masks on and set up some chairs and did a teleconference from there. So people do.
That is.
So when you say posted, you mean online somewhere, right?
Right, it's on the
So-
county's website.
On the
Yeah.
county's website?
Yeah, it's
Is that
the
what you're
agenda.
talking about?
Yeah.
Okay.
So our addresses are all on the.
No,
No, no.
no.
That's only
Your
the-
personal information is not on there right now. It's your bio that you wrote.
Oh, okay.
And that is the only information, but not your phone numbers or addresses. Unless you wanted to tell the help or tell it. Yeah,
You only have to give it if you decide to do a teleconference.
And just to make this real, 2 meetings from now, in April, I'm gonna be in Tunisia. Okay, 2 o'clock in the morning. I'm gonna make sure you know where I'm at. It'll be on the agenda, and I will at the beginning report if anybody else is in the room. So it's, again, it's an attempt to allow participation, but there are rules on which we have to follow.
And it says it has to be accessible. So if I'm meeting from my house, does that mean it has to be?
That's what I'm just asking.
Yeah.
Should be.
How much in advance do you have to post?
It's in 72 hours.
72 hours. Yeah, it's on the regular agenda, so SOPTA would put up the agenda, it would have the address where your main meeting is located, and then any other teleconference, addresses.
In other words, you're in violation if you don't do the 72-hour rule and you turn on your computer and log in.
Now, keep in mind, I'm giving you, like, this is basic, but we're gonna have some ways to get around this, okay? I'm gonna get into those now. But, oh, well, let me finish this slide first. So each teleconference location should be accessible to the public. At least a quorum of members have to be in locations in the county, okay? And then the agenda has to provide the opportunity for members of the public to address the legislative body at each teleconference location. And then members with disabilities, either temporary or permanent, they can participate by teleconference without posting their physical address, okay?
Well, the same. I have my alternative.
Aren't we all the same?
In some way or another.
So but this is, if it's a disability that keeps you from going to the meeting, all right? So, any participation by somebody with a disability is treated as if they're in person. So, that means they're part of the in-person quorum, okay, or the in-county quorum. And this comes in handy with some of the other teleconferencing slides that I'm gonna bring up that are those allowances. So keep in mind, anybody with a disability is treated as if they're physically in the room. And somebody with a disability, they do need also to say who else is in the room with them if they're 18 years of age or older. Voting, conduct only public votes, no secret ballots. That's even for electing officers. Public record of all member votes and abstentions. So the minutes should reflect how each member voted. If it's something that's usually unanimous, it's okay just to put that in the minutes. As long as you have the roll call listed in the minutes, people will know. And then teleconference votes must be by roll call. All right, so we're getting into an alternative now. So this is to keep you from posting your physical address, but still be able to be on teleconference as a member. This is new as of January 1st. If the Board of Supervisors authorizes it, then you can meet by teleconference, and they have to authorize this every 6 months. And actually, they authorize it, and then your board has to vote on it as well to approve it. So that's an every 6 month process. And if that occurs and it's approved, then there still needs to be a physical meeting location, although that only requires that there's one staff member, either staff of the behavioral health agency, one person, or of the Board of Supervisors, as long as it's one person. Then in a physical meeting location that's open to the public, so the public can come in, members that want to come to a physical meeting can come to that. I'm hoping and thinking that you all would probably be coming physically in person usually anyway. Okay, I think that's usually the preference if you can. And then let's see, public participation has to be facilitated, allowing the public to remotely hear and visually observe the meeting. So they should be able to participate either remotely or physically in person. And then disclosure of individuals who are 18 years of age or older, if they're in the room with people that are on teleconference. And then elected officials have different rules related to them. So the Board of Supervisor member would likely have to come in person. They have a higher level of accountability.
Can I ask a question about that slide?
Yeah.
If the public are unable to participate remotely, for whatever the reason, it's on our end, not their end. What are the circumstances? Like, do we continue the meeting because we have a meeting scheduled, but our technology is not working? Or is that meeting not fitting this rule, and therefore we would not be able to hold that meeting if we're not allowing the public participation?
Right, I'd have to look that one up, but I think you have to stop the meeting.
And if that be the case, then would we feel like this is a unpaid mandated law that we need money for technology? So that we are able to have the public participate consistently remotely to fulfill the Brown Act.
Well, keep in mind, you voted to do it, so it's not an unfunded mandate. You voted, or the Board of Supervisors voted to do it, and you voted to do it, so.
Jen's got money for technology.
I would say, for individuals with disabilities, you want to make sure, that you're doing, any kind of accommodations that are necessary. So that would be a reason to have a teleconferencing.
We are getting along. That's why. Wow.
That got resolved with having all
Having
meetings
the
at EOTs. That way we don't have to worry about technology, and it hasn't been an issue.
I missed that piece.
But if for some reason the technology breaks,
Yeah.
or we can't
Wi-Fi's
make it
down.
work because we just
Yeah.
don't, we're not smart enough. Then the case can be made, I think, but then it's better technology,
Right.
it is more support.
I mean, that's why, for instance, why I did propose that we change the site, the venue to Neo Thomas, because their audio visual is much more sophisticated than what we have at the lakes. And it's working out much better, so Southampton doesn't have any Wi-Fi problems anymore. It's quite frustrating to, like, even out in Guerneville. So it's a lovely setting, really nice meeting room, but the Wi-Fi out there was, the last time we were there was just,
It didn't
was
work.
terrible,
It didn't.
you know?
People pretend trying to figure this out.
Yeah, so so we're trying to take care of that now. But we shouldn't have to continue the meeting. Right. Yes,
We already need.
okay.
We have a quorum, so we can't.
No, but I mean, it's that day that we couldn't get.
Yeah.
That meeting should have
We should
stopped.
Technically, we should, even if we didn't vote on anything, we still wouldn't be able to meet. But.
Right.
So, yeah, my answer was to that last slide that you need to stop your meeting. But if you're just dealing with regular teleconferencing, rules, then it's okay.
Posted meeting, and it said Zoom access for anybody, including the public, was at this website, and then we couldn't connect when the physical meeting was not able to connect to the internet.
Right, yeah.
So the public couldn't have observed.
For regular teleconferencing rules, the first slide that I went over for teleconferencing, I don't think there's a requirement to end your meeting.
Oh, okay.
But on this slide, there is.
Yeah, there
Right.
is, yeah,
Okay.
for this
So-
alternative, there's more requirements.
So if you choose to give yourself more flexibility, you've got to make sure the public can.
Yeah, so you wanna make sure the public can attend.
Oh, okay, let's get to.
And then, yeah. And then state of emergencies, you know, if you have, maybe it's a wildfire, or, you know, you've had a number of emergencies in Sonoma County, then if the Board of Supervisors now can proclaim it if they want to. In the past, it had to be the state and then the Board of Supervisors. Now it can just be the Board of Supervisors can say, we have a state of emergency. Then your board can decide, you can actually convene by teleconference and vote to have teleconference. Okay, so they put that into law, so you wouldn't have to physically get together and vote to do it by teleconference. So you can convene, have a majority vote to determine that you're gonna meet by teleconference because of the emergency.
Yeah.
And then you have to vote every 45 days, as long as there's still a state of emergency. All right, so just cause allowances this is something that was put into place a few years ago. There were two different ways to do teleconferencing without posting your address on the agenda and opening it up to the public. They called it just cause and emergency circumstances. Now they've combined those two categories into just what they call just cause allowances. And so there's some requirements around that, and the next slide will tell you what the allowances are. But the first requirement is you must have quorum at one singular physical location. The second is there needs to be a member request. It can be before the meeting, or it could be right at the beginning of the meeting, that a member requests to participate by teleconference. There doesn't have to be any vote on that request. They just make the request and then they attend. As long as there's a quorum, they can participate by teleconference. Don't have to have any public access at their house, don't have to have their address on the agenda. They should be participating both by audio and visual. And then the meeting minutes should reflect the reason they're participating remotely, and the reasons I'll go through in a moment. And then there's limits on remote participation. For your group, it's probably going to be 2 meetings per year, and that's either a standing committee or a regular board committee meeting. Although there's a, if you have your board meeting the same day as you have a committee meeting, the Brown Act considers that one meeting when we're counting remote meetings. So that would be one meeting that you missed that year, or that, you know, during that period. So there's some allowances here depending on how you have your meetings set up. And then this slide talks about what are the just cause allowances. Childcare and caregiving need of a child or family member contagious illness that prevents you from attending in person, a need related to a physical or mental condition that's not subject to disability allowances, official travel on behalf of your behavioral health board or of any state or local agency, immunocompromised family member, and then physical or family medical emergency that prevents a member from attending in person, and military service obligations that require a member to be 50 miles outside of the meeting area.
Can you go back to C, please?
I think you're looking on here at C. Let's see. Number 30.
Need related to a physical or mental
Need.
condition?
Subdivision, what is that?
Yeah, okay, individual maybe exempted.
Oh, okay. All right,
You got it?
I think so. Page-
Okay, leave it.
Slide 9.
Differences in building is temporary or permanent.
Yes, it's relating back to.
This is the
That's-
subdivision C.
Okay, yeah.
Okay.
All right.
When we're requesting, and if I heard you correctly, we can request up to the point of the meeting before it begins to
Right.
any of these causes. I mean, all of our communication goes through subject for the
Right.
most part. So am I requesting that of her, or am I just communicating it? to
Yeah,
you,
you
and
can
then you have
communicate
to
to
somewhere.
her, right, she could communicate to the chair.
Because again, I'm just thinking like logistically, if it's gonna be just prior to my child is sick.
Right.
I'm not coming, you're probably already on your way to the meeting or something.
Yeah,
like
you
that,
could
so
just
it's that-
dial in, get on the teleconference,
Okay.
if there's already, a teleconference set up, and just notify
State
them at
that.
the beginning of the
Okay,
meeting.
all right,
Yeah.
thank you, yeah.
It's
I was
good
like,
to
how am
know.
I gonna get a hold of you?
Yeah, and it's good to note that I don't check my emails, an hour and a half before the meet, probably more, because I'm literally packing everything up,
Yeah.
traveling to our meeting site, setting up.
Yeah,
And a lot of people like to email me like a few minutes before the meeting starts and tell me
That's
stuff,
true.
and I'm sorry, I'm not checking my emails during the
Yeah.
meeting,
Yeah.
so just keep that in mind, please.
yeah, no, that's why I was
I'm
asking.
not gonna respond.
Yeah, no, that's exactly why I was asking, I'm like, I did her, she is on the way, when I do.
And I've seen this in the Santa Rosa City Council meeting, at the very top of the agenda, the first item is anybody out there who's a member of this body who needs to take
Yeah.
advantage of the alternate? And usually there's nobody, but I've seen a couple of times when they said, hey, it's me, my kid's sick. It's like,
If that counts, then great.
yeah.
That's good to know.
Okay, and this last slide just talks about frequently asked questions. Sometimes I'm asked if it's okay to do a closed meeting. Usually no, not for an advisory board. There might be something that comes up really, I don't know, if it's something related to staff, if maybe a staff member has something that they want to express to the board privately. But usually that doesn't happen. I've never heard of it happening. Or if there's something in litigation that maybe the agency or the county wants you to know about. If something that is related to that, the Brown Act Guide, I think it has some information on what those different categories are in more detail, but there's not a lot of reason to do closed meetings. Conference attendance is okay, although we do suggest you sit apart from each other. If it's a conference that's sponsored by somebody else. Lack of a quorum is okay for you to have a meeting. You still need to follow the Brown Act rules. If it's a regular meeting, it's still subject to the Brown Act, even if you don't have a quorum. And then retreats like today, you do need to abide by the Brown Act rules. And then serial meetings, I talked about a little bit, we don't want any kind of collective communications that happen between meetings by email, phone calls, or Facebook or whatever the media ways are, or even by a third person. I don't see that usually happening with behavioral health advisory boards where you don't have a lobbyist that's, contacting every single member. Usually not the case here. All right, any questions on the Brown Act?
There is a line on the end that says we're supposed to make a complete copy of the Brown Act.
Oh, yes. You are supposed to have a complete copy of the Brown Act. And that should be given to all members. What I recommend is giving them a link to it. And, you can have a link to this document. This is probably better for your members just because it's more related to what's in the code. And this is already 8 pages.
And we don't think unless the county board of supervisors and the council or Sonoma are off the hook. I think that, because every time I talk to them lately, they say, we're still trying to figure out what 707 is about.
Very complicated.
I know, so, but the answer they tell me is, it will be soon, and you'll get a briefing from us and a copy. So listen, be aware that it's coming, I guess. Yeah.
So this is has the complete Brown Act.
Yes.
Okay.
Yeah.
So
We have the training, we have what I just went
Okay,
over,
got it.
reporting and training materials. So yeah, that's all there. I'd be very careful about when the Brown Act is shared, that people know that it applies to a lot of different entities.
Yeah.
And it's usually like the chair or executive committee that really needs to, and administrative staff that really needs to know. There are parts of that document that will confuse people. They'll think that things that only apply to the board of supervisors apply to this board, and that can be very confusing.
It will be good to have orientation member. I'm happy the 20 members are here today because I remember coming to meeting and hearing Brown for a long time and I didn't have a clue as to what exactly people get reference to. So it'll be something that we'll be doing, that when new people come to orient them to the Brown Act, because more than likely they have never heard of it. And if they have not heard of it, they want to know what to expect or know the expectation of it. So we go to make that part of our orientation.
I heard someone say that they thought it was something that governed how people who are brown should act.
Gosh, I went past there because I'm the Browns. More shit at the Browns.
We all laughed around.
And it was meant to be a joke. Yeah, so thank you very much. Any more questions? I know we asked the questions along the way. I'm sorry we somewhat interrupted your question. We not anything. So
And Teresa's coming back to do another section.
pardon? Yes, yes,
Yes.
Yes.
That's small.
So we'll take a short break and then we move to do the other session. And then talking about what we keep, what's priority out of this gathering. It's very important.
Next job on the list.
I put out some chocolates if you guys need them.
I'm spoiling this.
And you can keep your way.
I'm gonna have to leave it
I
too.
was wondering, is there a commission that is called the city?
No.
Oh, maybe I'm told in the next one. I was sent.
Yeah.
Is it them?
Oh.
You do.
And, you know.
She's just out there.
My introduction to the that's fun. Difficult. Not to mention. That's the four things, whatever. So it's the first time. I can hear them. That's. Yeah, I'm sure you're. My adult. That's interesting.
Like guidelines are specific. I'm surprised they gave the name all.
Well, it is, yeah. it's
Yeah,
the box.
here's.
This is my grandson.
BHB Annual Retreat2026.
He's like 2.5, he's gonna be 3 this
And
summer.
this stuff.
We call him Tina. For sure. And then I have, it was so smart, but.
So is there? Is
My other
there?
grandson is Jack. Jack is just.
Well, it's chairs and administrative liaisons is what we call it, because every county, which is same like that. Call it. administrative.
Oh, they go
All
up
of that.
and
Sometimes it's their.
Yeah.
It's depending on how large the county is, so.
So different, you know?
Yeah, Tina's really dark,
For that.
eyes.
On our website,
Yeah.
so, because that covers,
Yeah.
is just the training that I'll do right now. That
Yeah, I
it's
don't
good
know.
to have this, just so you know, the basic routines and everything are.
Yeah.
And what's, what is this using?
It's only, but, and I know that it's shifted, it's changed. Like I said before. I'm like,
It's the reason around the office, this is like I'm starting to hire, we're in fireplaces.
I was asked.
Wait, the whole time I was like,
Even also.
I think we're pretty fast, because I've used this room for
Because I.
retreats for my team.
Okay. I want everything. I think we did after I made sure that, was did, and there's. Always doing this. So it's very. Especially when I'm like, oh, I was. Very.
Oh, and now you're in it. I don't know if they let.
Yes, right, it was survey.
But yeah, do more fun. We should,
I spend a lot of. Time.
I'm okay now, like at first, when I was in here the first half, I was like, yeah, it's cold, oh my god, I get this. I know it, get outside. He went in, asked them to heat up for us.
I have to advance my time, so I can. With her.
Yeah, but we have to.
Brains not the next few days.
Yeah.
I didn't literally just making sure that everything's set up, then backing up that.
Glad I didn't wash my car.
Right. Yeah. Well, what the correspondence that you're getting, is it from the board members themselves, or is it just?
It's a lot of process.
Yes. So we have.
I'll talk to that. Trying to reduce that.
What are you gonna say?
Because they're a board and they need to work together as a board, they don't want to add your staff. If that's, sometimes it looks like that.
Oh, and you're having one of
He
And
knows that the county will basically say we're.
I've never thought about.
When we get to that point, if the board of supervisors says, here's like some of folks who need.
Then one,
They have something
two.
to talk. That there's some ask.
Oh, I was.
I think that,
Except.
would
Yeah,
say
but-
maybe it's it should be like farmers
Maybe
maybe.
in a zone.
So
People are
it's just going to work.
Take power.
So you go to the internet.
What we do if you ask for. Maybe saying, well, more money to the big.
I mean, always in my- Those in your-
They will instead of meeting up with Chris and most of Chris, because he's the leader. Oh, yeah, we always.
Okay.
Yeah,
And-
that's
and-
go for it.
Yeah, and I don't wanna call him in in public, but I will in private, because I think he needs to understand. Most of us who hear that from it,
It's more
think
than
he's lying, he knows he's lying. And we want to say, if he says no.
He fumbled on the special site too, and I didn't have enough time to get deeper into it, but it was on his browser, I was like, sports seeds.
Yeah.
Yeah, I do not
Another
question
question
any
in
person
response to that, and I was like, that's not there.
He's like his own. Sure.
Right.
I send him a lot more. I would expect.
Yeah, we do.
Chris, I
Yeah.
understand work intelligent comments.
Well,
It's nice.
We do think about.
So we're not.
You have you guys don't know if you've been talking.
Well, yeah, we put that with the.
Yeah.
So
I
what
think
we
it's
contract-
some of
Yeah,
my
I agree. Yeah,
colleagues.
this is the most precedent of
So I I get it over the pen, I thought another point.
Sure.
I'm not even sure. In the chair's training, we'll talk about chairman exercises like the
Northern California, like, or what if they also use like hospital here.
It's not only in the meeting, but in the session.
And so it's,
Not
yeah,
to say
and then
that
to get overall the becomes
This chair.
yeah, it's like,
But
now
hopefully.
they. Right. The bad part is like.
Both of them.
End up in the get on 5150 off.
Yeah,
And then they just send out referrals.
Yeah.
For the database. And unfortunately, the vast majority of working with several counties, we get both from home. Is to make sure they pass to the county.
They just want-
Right, but we spend a lot of money.
I was talking to a girl in California about the legislation action passed and talking about highlighting that. And they were like, yeah, and I was like, yeah. So if you have to money to implement.
Yeah.
These legislation, that's what is there, you know, like.
Something that you can really.
Yes.
Well, it's a majority is funded, to be honest, like, yeah, majority are county funded and whatnot, this is. And we get a lot of money, there's no problem, it's stuff, but our legislation, commercial, and just. They have their own media workshop type thing.
Yeah.
He's got the-
That, you know, you can just give it to, and honestly, you're. Some people, that's more information than they want.
Right, and it's.
But
Yeah, I can scan this and.
we rarely have any batch of happenings there.
Everyone.
Yeah.
Yeah.
We get a lot of more.
That's all right.
That's it. Yeah. Well, so it was, that was actually before now, since Santa Rosa. Yeah.
So that,
Yeah.
yeah, the one thing
Your
I.
issues are to you and the constituents, but the question.
Developing, yeah, and it's hard because we don't have a program specifically,
Do they perceive?
and so that we.
You get behind the door.
There's really,
Like,
right, home can't handle.
Yeah, and I know that
Right, and
There's
my
not a lot of
critical
options.
issue is,
you know, I have a lesson to do that is age 13 to 17, and that
it's
adds
not
up.
that I have to fight for people to agree.
Yeah.
It's more
Yeah,
than.
they're so fall. Yeah.
It's all.
Oh my God, I have to take care of myself when I walk over to you. Okay, but it's certain things, like the mom came out, and
Well,
when it
how
was
do
one
we
girl was like,
get
that's not.
other
You know,
people?
it's like, oh, so you know what, we'll watch your mouth, like, you know, it should. Well, still, it should. It would all.
You were all.
Okay.
You were all trying to.
Oh, no, I remember. Oh, there, this is my event. Yeah, my first. Oh, he loves.
Oh, it's not. Threshold. It's one of the favorite items.
Okay, all right. I can imagine that.
But we have, like, it's
Well, I'm not sure he's right.
That's like, you have to pick on the side, so it's just.
Yeah, and it's only during.
Unless you're.
Well, right.
Sometimes I.
Yeah.
In my coalition.
Oh, you know that one person. That kept coming back, now they got 50.
Yeah.
Oh, I was considered. I just was at. GIs.
And there are politicians who've been masters.
Yeah.
And there's one of the heroes.
Yes,
Opening ourselves.
and I can find those like with that. It's a lot of issues.
You do a pretty good job of.
Right, well, they do have.
It's not us.
Right, so you see that, and then they have right at. Yeah, and then they can go through the level hearings where we were doing that. I don't like.
Most of the time. That's.
So source of income. Like six.
Enough input. So I'm handing it back over to Teresa and it's all this, I like to stand.
Okay, so, I just wanna, I have to leave it too, so I don't, when I get up to leave, I don't wanna see reading. Just wanna thank you and thank everybody, I think this has been great, but I'm gonna sneak out on it too. So, okay,
Thank you.
Yeah.
All right, so I'm gonna be, so, this morning, you talked a little bit about some of your duties, so I'll be going over those again, but talking about tools to use, and some of the reports and things to look at related to your duties. And I'll talk about, membership requirements, meeting rules I've already talked about, so that's good. And then, other tools that we recommend. And keep in mind that you're all experts in your own experience, however you experience the system, whether you've been a person that's received services, or you are a family member, you're a member of the community, you know, provider, or whatever the experience that you have. We want that to inform the system here locally. And I'm always listening to, you know, we want that to inform the state. And the state wants you to be doing this work as well. So this is state law that you exist. So we'll be talking about both membership, meeting rules and conduct, duties and tools, the Behavioral Health Services Act. Just a little bit more information in particular to that. And then just recommendations on how to review and evaluate, but keeping in mind you're experts in your own experience. So I could give you suggestions on what to do, but I don't want you to think that you need to be an expert in behavioral health at large. This is a new language, especially for people that have just come onto this board. And even for people that have been on it for a long time, they don't know what all the acronyms are and what all these programs are. There's a lot in the system. For membership requirements, there are 3-year terms that the members are appointed by the Board of Supervisors for. They can be renewed. There should be a 10-member minimum for a county this size. 50% of the membership has to be either consumers or family members. And a consumer is defined as somebody who has in the past or is currently receiving services. Either substance use, alcohol, drug related, or mental health services. Doesn't have to be in the public system that they receive the services. And of that 50%, one person should be 25 years of age or younger. There should be one Board of Supervisor member, one employee from a local education agency. That could be anybody working in any school or any local education agency. It just, it could be, it could be a teacher, it could be a counselor, it could be a janitor, just has to be an employee. And then one veteran or veteran advocate. It should, and a veteran advocate is very open. It could be, somebody that advocates for veterans, but it could be a family member of a veteran. And then it should reflect the diversity of your local client population. So the clients that you serve. So it should be diverse in terms of ethnic, racial, cultural, LGBTQ plus, and age, and geographic as well.
Yeah, in that case, we say it affects the diversity. If, say, for example, somebody's willing to serve, and then we have a large number of people in that particular space, do we turn them down and say we can't have you and look for a particular ethnic group or to make it more diverse?
So you do your best, right? You can't dictate who's gonna apply to be on the board. But you can be intentional about recruiting. So if you know that this county has 40% of people that are Hispanic, Latino, then you might want to go to places where there are community groups or religious organizations or something, some type of institution where you would approach their leadership and say, we have a behavioral health board in this county and we would like representation. Maybe, ask the leader of a community organizing group, related to that population or somehow, or maybe it's through some of the programs the behavioral health offers that you could find people. There may be stakeholder committees that this county already has that may have members. Maybe there's a priest that could recommend somebody in his congregation, or there may be ways, but be intentional. And I say, I would sit down with people, I would target them and I would sit down with them, ask for coffee or lunch or something, and talk about what the board is, why I think it's important, why I'm on it, and ask them, do you want, or your family members have any past experience with behavioral health? And it's always been a yes answer. So generally people do get engaged if you sit down with them or on the phone.
Yeah, it has been a challenge. It has been challenging over the years regarding diversity on our board. When I started a few years ago, when I walked into the room, with due respect, I saw a bunch of people. Every single one was over 65, and they were white. And having lived in that county for the length of time I had lived in that county, I didn't think it was a representation of the county. And they were happy to see me. It's like, oh, so somebody is interested. And I was like, I have to tell you, I'm not coming in to represent Black people. I'm coming to serve the community. I just didn't want to carry that burden. I'm coming, my interest to serve the people in the county. So there are times we have had a few medical moderators that who don't stay for long. And I don't know how to get to the diverse population of this point. But now that you said, go and have coffee, that's another assignment that I would be happy to do because although I don't drink coffee, I'm gonna drink.
Yes. Drink coffee.
There's
Yeah, and adding to that dilemma of trying to find people who will apply and fill those positions, we have boards of supervisor members who, at least a couple of them have sort of said, don't mess with my applicants, like, or my recruitment.
Yeah.
And we've gotten messages from their staff that until they get appointed, we're not even supposed to talk to them. So recruiting people has been a difficult task. What I've done for the 2 or 3 who said, sure, Gregory, if you can find somebody, I'll interview them. Opening up the door for us to be able to say, okay, who are we missing and how can we do the kind of strategizing? But that's exactly, my strategy is exactly what you just described. We don't have a whole lot of minorities and we don't have a whole lot of young people. So I'm going to those groups that concentrate on assisting those target groups or are those target groups and giving the same pitch about, your clients, your staff, your friends need our services probably, and that we're not going to be able to deliver them very well if we aren't having people who are on board and demanding. So keep up the exact strategy. I still think, if we're taking inventory, I noted that today we have 2 of us who said that they work for school districts. I had no idea that they were doing that, and our requirement is that we have somebody, so I'm happy to report that we do have some. I represent veterans, we've sort of got the veterans, don't have under 25, and we don't have many of the minorities, so we need to work on that.
I will help take up that task for sure. I'm connected to a lot of people not through my work with social justice, but
At the
at the
San Rose College.
school, yeah, so I will definitely be taking up that task.
okay, thank you. All right, please. I didn't want to.
Great. And the other thing for folks that are under 25 and even people that are over 25, the time of day for your meeting can make such a difference.
Definitely.
And for youth, sometimes transportation is difficult, so there may be ways to allow them to attend by teleconference just by having a teleconference location at whatever, if they're at a school, community college, have a meeting there. You're going to get more participation from that age group as well if the meeting's located on a site like that. So you could have 2 locations, where you meet together normally as well as at a school.
That's a great idea. Yeah, that's awesome. I have access to rooms too, I can pull people in and get on Zoom, that's great, yeah.
And keep in mind, SACTA is only 1 person.
Yeah.
You would need like somebody to help facilitate.
For sure.
Yeah, thank you.
Okay, sorry.
It's all good, right?
All right, so, the next category is just individuals with experience and knowledge of the mental health system. And the state lists a number of categories, but it's such as, so it's kind of broad, but just trying to include all of the sectors that intersect with mental health. And then There are exceptions. There are people that cannot serve. But then there's exceptions to the exceptions. So if a person is working for California's Department of Healthcare Services or this behavioral health agency, or is a contractor of this behavioral health agency, unless they actually have lived experience, they can't serve on this board. If they have lived experience, if they in the past or currently have received services for behavioral health, and they are not over contractual or financial matters, then it's okay for them to serve on this. So it's okay if they're a consumer, as long as they're not like the executive director of an agency or an organization, or they're not working in the behavioral health agency overseeing contracts, or financial, and they're not the CFO or things like that. So it's real specific, but there's a lot of people in the behavioral health workforce who have lived experience, so it opens it up. Okay, and then we'll go next, since we went through the Brown Act, to conduct. Conduct within your meetings for your board members. This was put together based on what we've heard from other counties and witnessed in terms of, trying to get through a meeting where people treat each other with dignity and respect and are able to focus on behavioral health and focus on issues and focus on getting to recommendations to be able to advise. So first is active listening. And we mean listen, listen, listen. We don't mean listen and come up with your reaction in that moment. Because once you start coming up with your reaction to something, you're not listening, right? So there'll be time to react, but you're in this for the long haul, 3 years, right? For your term anyway, maybe longer. So make notes if there's something that you need to respond to, but try to just listen to each other, listen to the staff, listen to any presenters and the public. Focus on issues. And when I say issues, I'll refer to this document, Behavioral Health Continuum document that has on the right-hand column a number of issue briefs. And these are areas where we tried to, provide information on some of the the needs, the gaps, the barriers, the challenges, but also the successes. What does success look like? What are those key components? So these are areas where sometimes these issue briefs came out of a report we got from the county board, where they went in deeply into an issue and came up with some recommendations. And then sometimes it came from a state report or document. But we looked at a lot of different topics, and we didn't just look at like these big problems like homelessness. We would say that's a big problem, but you can't solve it by just taking just going after it like Don Quixote, and windmill. It doesn't work that way. That's not the right tool. Breaking it down. So board and cares was the issue that we came up with because we saw people were cycling through the system. And a lot of times they were, probably 10 to 25% of the people that were going through like transitional facilities, they like the time would be up to 18 months that they could stay there. the staff was saying, we are seeing them go back to homelessness after this because we don't have a place to put them. So boarding cares became an issue brief. And keep these issues in mind as you think about, for the next part of the afternoon. When you decide what areas you're most interested in looking at, for the upcoming year. Maybe items like these, it might be, it sounds like you have specific concerns regarding, keeping your mobile crisis going, some other things. But these areas might be of interest to some of you.
Let me just put a pitch in for your website because as Jan just noted, it's very good. And you have done the kind of research that all of us need to know about, whether it was last year, 2 years ago, or even right now. When I go to the meetings, I'm the board's representative to her coalition, the association. And every time I go to a meeting, there's something I go, oh, I gotta bring that back to Sonoma. Psychiatric advanced directives, privacy, patient rights, lots of things. So it's important for all of us to keep track of what you're doing. I'm trying to do my best to bring back some of the issues, but her website lists issues that are current and are continuing, and the minutes and other materials that come out, and the taped meetings that she holds, because she does a really good job by trying to capture everybody's voices and everybody's issues at each of the meetings. So I'd recommend that we keep an eye on those meetings, keep an eye on what issues are coming up statewide, because they can often be ahead of us. They can also be colleagues and partnering in issues at the state level, and it's a valuable resource.
All right, so next item is person first language, which is a different way of speaking where you put the person first, not the diagnosis first. Because people are many, many, many things. There might be schizophrenia, there might be bipolar, there might be substance use or alcohol use, or lots of different aspects, but that's not the only aspect. So we need to say things like an individual with schizophrenia, a person with mental illness, or people with mental illness. We don't say the schizophrenic, we don't say the mentally ill. And it is a change for a lot of people. I've heard those terms already today. So, the not person first language. And I know that that's just part of the way people speak. But for you all being on this board, we recommend that you try to do person first language and model that.
Yeah, it is something that the individual who's referred to as the diagnosis can have a negative impact on the individual. If I were to share my own experience, I remember at age 43, I had a stroke. Now, I remember that first night I spent at the hospital, I heard a nurse referring to me to another and said, the stroke in room 260, I remember evaluating with the room. The stroke in room 260, and I was like, I'm in room 260. I'm not the stroke. I'm looking at myself, I'm looking at the bed, and it's like, I have all those years I cannot use my left side at all. And I was like, the stroke, I heard it so many times. I was like, that's what you're reduced to? And I was like, Lord help me. Because it's like, all you hear is the diagnosis, not the person. And you feel like you have been reduced to zero. It's like, so in your mind, when they walk into the room, they don't see you as a person. Because all you'll be focusing on is the diagnosis that you have. And they will be missing 9/10 of you, because this stroke or this diagnosis is just such a little part of you with all your background and everything that makes it the whole person. So I really understand when we see person first over diagnosis because I've heard I'm not schizophrenic. I'm bald. It's like, they can get to you on a psychological level and really demeaning you as an individual.
A lot of like, places are even stopping using terms such as client, patient, and referring to people in the first person.
Like I did.
Yeah.
A guest in bridge housing, I think we call, instead of the patients, for clients, the guests.
Yes, yeah, that's one of the, that's one of the things,
Yeah,
yeah.
home guests.
Exactly, yeah.
At CC, we call them residents.
Yeah.
Yeah,
And it's a huge difference how they be referred to and
absolutely.
how it has more value to you as an individual because, well, that's like, I don't think I slept because I was reduced to a stroke. I was like, I'm more than that. I'm a husband. I have 3 kids. I was like, I'm so much more than this stroke. This is just happening. Less than 24 hours. I mean, just that. It's so I understand that aspect of it very, very well.
All right, next item, no swearing, if possible. Sometimes people swear, it's just part of their vocabulary, and the public sometimes does, but try not to. No personal attacks or criticism. If you feel like personal attacks, then look at number 1 and number 2. There's active listening and focusing on issues. That's where we want you. Even if somebody attacks you personally, you focus on issues and listening. Always be polite, even if people aren't polite to you. One person speaks at a time, no sidebars. Even when people are whispering, it's distracting to people in the room and the speaker.
Sorry, if I can just add to that. It's hard for the owl to pick up on conversations as well, because it's recording and it's, recording whoever's speaking. If there's side conversations, it's been an issue.
It gets confused.
It does,
They
get
all
confused.
get confused.
Yeah. We don't want to confuse.
It kind of just confuses the sound.
It does.
Right. Keep comments short if possible. Do not monopolize. That can be a big issue, and I notice a little bit of that in this room, so I'm gonna just stop on this one and say, be careful if you think that you're one of those people that talks a lot. You probably are, and they can be difficult to get through a meeting if you talk a lot. I know that each of the members here wants to have their points heard, but gotta make sure to get through the meeting. Limit acronyms. When in doubt, spell it out. So just about everything. Anybody and all the programs here at the Behavioral Health Agency have different names that the staff is very, very familiar with. So when they speak, they might mention the acronym or they might mention the program. But it's not just acronyms, it's programs too. People don't know what they are. These are, somebody coming in might not know what a full service partnership is, right? That's not something, and even the Behavioral Health Services Act. I remember coming onto my board a number of years ago in Napa County, and they talked about the Mental Health Services Act, the full service partnerships, and I thought, I had a lot to learn, and I didn't want to say anything at the time because they just thought I should know this. I'm on the board, right? Yeah, but people don't know. Silence your cell phones. And if you have a speaker or member of the public talking to you, that's not the time to check your cell phone. We notice that a lot when people, especially people if they have heavy accents, or if they're saying things that you don't agree with, We see members starting to check their cell phones or look down or shuffle their papers and look at something else and do other things. That's the time that you should really be paying attention, or at least just try to pay attention, try to focus on the person and just treat them like everybody that comes, whether you agree with them or not, or understand them or not, treat them with dignity, respect, look up, pay attention.
You know, in school, they take the cell phones now, away from,
They
you know,
just take them
you have to
away.
turn your cell phones in, and. But I think as adults, we should monitor ourselves, right? We don't need to hand our cell phones.
Not to me.
I put them in a locker. Maybe we should. Because I think it can be annoying when people are,
Right.
but sometimes if you have an emergency or
You
something.
have to check, right, yeah, some people have to check because of work or family, and sometimes people, because of anxiety, they use that, so that's okay. But just as a good practice, try not to. So we're gonna start talking about each of the different duties. These are all in California law. We're gonna go through the 8 duties that were on the paper from this morning that you all saw. The first one is review and evaluate the community's public behavioral health needs, services, facilities, and special problems in any facility within the county or jurisdiction. So the tools that we suggest would be things we probably already doing some of this, speakers, panels, community forums. When you get a panel together of speakers from different agencies, that can be really enlightening sometimes. Like if you were focused on school-based services, you might have staff from the behavioral health agency, staff from maybe a nonprofit that works with children and youth, a wellness center from a school if there is one, staff from the school, county office of education, school counselors. You know, you could have a wide variety depending on what the topic is. And once they get into the room together, there's going to be less finger pointing and more discussion. They hold each other accountable and you get a better understanding of the system that way. The second is have liaisons to other commissions and committees in the county. So you would have a member that attends their meetings. Maybe if you had things to report from your board, they would do that and they can bring information back to you. Site visits, and we have documents for site visits just to help you to have good procedures for setting those up. Usually it's definitely less than a quorum that would do a site visit. Usually it's 2 or 3 people. Sometimes it's just 1, but 2 or 3 people is usually good to do a site visit. And we have an observation form that we recommend to use.
Is there an updated observation form? Because I think the one we used at the last site visit was a little dated.
Yeah, I think we look at what might be on the side.
Yeah.
This page.
Oh.
This part is there. Function gates. And the update hour.
Actually,
Is it, yeah, it's in this binder. And
Actually, Napa had a really good one last time. I was over at their meeting, that the chair over there was willing to share their site visit.
right, and it's the same, almost exactly the same when it came out of Napa.
Yeah.
Thank you.
Ad hoc committees are a good tool, so less than a quorum, short-term, limited to take a close look at an issue. And usually an ad hoc will be doing what I would call research meetings. They would decide who do we need to talk to, and ask the chair. That the chair is really the liaison with the behavioral health agency. Find out who can we talk to, or who would be the right people. the chair could check with the behavioral health director and find out, you know, what staff locally here in the agency would be the right people to talk to about an issue. Have research meetings with them, or if it's something that intersects, or maybe a contractors, you know, have meetings with them, do research on the internet, look at Cal BHBC's website. We have over 30 issue-based pages, so you can see different areas. And then there's also performance pages for all the counties, so you can see how they're performing in different areas. So you might want to look at that too. All right, go to the next page. Next duty is review any county agreement entered into pursuant to section 5650. So California law, it is very complicated. It kind of points to different sections within the law, and this section points to an agreement. This agreement's called the performance agreement, and the performance agreement is signed by your behavioral health director. And within that agreement, it says that they have consulted with you. Okay, so if there are contracts or major agreements or major plans, they should be consulting with you, okay? And when, since this talks about any county agreement, we think that also means what kind of agreements, what kind of contracts has this behavioral health agency, this county entered into with contractors here or outside of this county, because there are certainly some services they contract to or outside of Sonoma County. So we want you to be, you know, looking at those when it's appropriate. Let me start with strategy number 3. If you're going to do a site visit, that's an appropriate time to look at the contract. Look at what are, you don't maybe need to see everything, but the things that we would say to focus on would be the deliverables, you know, what is expected within that contract. So you have an idea of what this agency or organization does before you visit, what they're required to do, so you know what that is. And then there will be times when the county needs to contract for a new service. So that's number 2 here on the strategies with what's called RFPs or RFAs, request for proposal or request for application. So when they're doing that type of process for a major new service, that's a good time to have less than a quorum, maybe, you know, 1 or 2 people usually involved in looking at applications, maybe interviewing potential contractors, but being incorporated as part of that process when the contractors are being selected. And then staff presentations and reports on data. So, well, not just data, but recommendations that have come out of audits. So for Medi-Cal, there's an annual audit called EQRO, External Quality Review Organization. And the audit is, it results in a very, very large report. And we recommend that you look at the recommendations section, which is usually the page, and the performance improvement plan section. So you can see what are the 2 areas that are really, you know, focused on in terms of improving the services. And we have this information on our website where you can get to it. If you go to performance, it's one of the tabs at the top. Go to your county and you can get to that information. And then Behavioral Health Services Act, within the integrated plans, they will have information on performance of the different programs. For you all, we recommend that you're reviewing needs and barriers and challenges, but also successes, hopefully, and looking at the data that is there in terms of performance outcomes. And we talked about that a little bit earlier, and I'll talk some more. I have a slide specifically about that, looking at performance outcomes. And then SAMHSA, which is Substance and Mental Health Services Administration, they have grants, some large grants, small grants that the county is likely, I think Sonoma County probably has. And there's a lot of data and information related to that in the applications. So when the applications are being completed, that's a good time for staff to present to you. Duty number 3 is advise the Board of Supervisors and the local behavioral health director. So if you're going to advise, we would say do it with good structure and procedures so that you're advising as a body. We don't think that you should, be as individuals all making recommendations. It's fine to be discussing that together, but as a body, when you make a recommendation, it has more impact. So first would be identifying what you're going to advise on. So listening to public comment, looking at performance outcome data, presentations, having the liaisons to other boards and commissions. Today, actually, after I do this training, you all can talk about what are the areas that you think are the biggest issues. So, that's another way during your retreat to identify. Secondly, research, use ad hocs to conduct research meetings. And we have a page on our website, a resource that provides information on how to do an ad hoc and even a form to fill out just to make sure you're within Brown Act guidelines, that you're not doing anything that would be outside of Brown Act by doing ad hocs. But ad hocs are flexible. You can meet by teleconference, you could meet for coffee, you could talk by phone or text or email, as long as you don't have a quorum and short term. And then the chair can meet with the behavioral health director. Site visits are a way to do research. And then once you've done the research, then advise. And we have a page in also a resource on our website that provides some information on making recommendations, just a process to do that, maybe using first an ad hoc, then going to the executive committee for approval, or maybe changing the draft recommendation and then bringing it to the full board for a vote. Okay, and then vote on the recommendation. And once a recommendation is made, communicating that, it could be communicated, like maybe, could be like a memo or a letter to the behavioral health director if it's, directed at the agency, or to the board of supervisors if it's something that's more under, a community need that's outside of the behavioral health agency's control. If it's done in your annual report, then it's, you could compile whatever recommendations you made through the year and provide that to the board of supervisors in your annual report. Duty number 4 is review and approve procedures used to ensure citizen and professional involvement at all stages of the planning process. So I think the question came up earlier today. Does that mean also our board meetings? Yes, set your board meetings at a time and place that is convenient for the public. Encourage public comment, make things accessible, publicize the meetings and topics. There will be certain groups that will come depending on what the topic is. So you can create a flyer, send it out through, there's next door and you have a newspaper here. Not all communities have those anymore. But just try to get that information out. You can do it by radio. And then look at tools such as staff presentations. They should be providing you information on this planning process. I'm going to switch over to another presentation because we have one just on community planning. And I want to show you just some information on what some of the requirements are for the staff. In terms of this bigger. In terms of the Behavioral Health Services Act, I want to make sure you're aware of some of the philosophy and principles and requirements around that. The funding for community planning, the agency requirements, and then your requirements and toolkits that are available. So in terms of philosophy, principles, and practice requirements, there should be an emphasis on the recovery vision, that people have hope they will recover. We have lots of stories of that, and people do receive services and they do recover. There should be promotion of concepts key to recovery, hope, personal empowerment, respect, social connection, self-responsibility, and self-determination. There should be efforts to promote consumer-operated services. And then 3, reflect cultural, ethnic, and racial diversity of consumers by addressing inequities. And then number 4, plan for each consumer's individual needs. The funding related to that, the agency can spend up to 5% of their full Behavioral Health Services Act funding, which is quite a bit for planning purposes. So that pays for it pays for your board costs like today, and it pays for consumers, family members, and any stakeholders to be part of the planning process. And then the agency actually has administrative revenue or administrative funding that can also spend on top of that. The staff also is required to put together what's called cultural competence plans. And they must show a commitment to cultural competence. This is actually a federal requirement right now. So there's, because of the federal executive orders that have happened over the last few months, there have been some pushback on these cultural requirements. I think there was an executive order that said we can't use the term cultural competence. So, but keep in mind, this is still required by the Health and Human Services Agency of the federal government. So commitment to cultural competence, there should be updated assessment of service needs. So needs assessments should be done. Strategies and efforts to reduce racial, ethnic, cultural, and linguistic mental health disparities. Client, family member, and community committee. So there's usually what's called a cultural competence committee in each of the counties. Some of them have multiple cultural committees. And then there should be culturally competent training for staff. And the county should commit to growing a multicultural workforce, hiring and retaining culturally and linguistically competent staff, language capacity, and adaptation of services, because, for cultural reasons. So this is all part of planning requirements, these cultural competence plans. So that's the summary of the federal requirements.
About a month ago, Gavin told us, none of you are federal officers, none of you are federal staff, you are not affected by the executive order saying cultural competence, and he said you all work for me.
Oh, okay, well,
I'm just telling you that the cultural competency, all that stuff that was in the orders that some people seem to think affects grantees. He's saying in California it doesn't because none of you are working directly for the federal government. That's just,
yeah, okay. So
I'm
in terms of the local staff requirements, I put in and highlight some of the text related to the powers and duties of the behavioral health director. And the area that I highlighted is related to your board. So it says, recommend to the governing body after consultation with the advisory board, the provision of services, establishment of facilities, contracting for services, or facilities and other matters necessary or desirable in accomplishing the purposes of this division. So just pointing out, that this is required. The behavioral health director must do this. There's a long document, again, on our website that provides the 29 stakeholder categories. These are all different stakeholder groups that need to be involved in the planning process here in the county. And so because there are so many, it's important to keep in mind the meaningful part, right? At the top, I put that in italics, meaningful stakeholder involvement. So for some groups coming to a big meeting, that's fine. That's all they want, let me be involved in that. And for some community groups, they may be very astute at contacting staff and, just inserting themselves into planning. But then for unserved and underserved groups, they're not going to come to a large meeting. They're not going to come, to a town hall or to a community forum or VHSA planning committee group. They're just not going to come. So there are a lot of different tools that can be used other than big meetings. And it's important that the staff recognize that, and within their planning documents that, and presentations to you, you should be looking to see that all these 29 stakeholder groups, especially the ones that are traditionally or historically unserved and underserved, that you see that there is a concerted effort to include their voices. The Department of Healthcare Services has put together a list of tools, suggested tools for this. And that includes education and engagement to support meaningful involvement, listening sessions. And I put a link next to that because our association has created a toolkit for listening sessions. We see that as a way to get the voice of unserved and underserved groups. We have information on what to do prior to a listening session in order to get one set up, and then how to run it and facilitate it. So we think that's a good thing to do. Usually it's using the leadership of a community organization. And asking them, can we do this? And then can we use your people to run these small groups? When we ask these questions around what are your needs or what are your stories around receiving behavioral health services? Conference calls can be used, client advisory meetings, consumer and family group meetings, town hall meetings, video conferences, media announcements, targeted outreach, public comment, public hearings, which happen during your meetings, stakeholder work groups and committees, focus groups, surveys, and then key informant interviews, do phone calls or, one-on-one meetings, and training, education, and outreach, and then they just say broadly other strategies. So, this kind of, this community planning points to how important it is for your membership to reflect the clients served in this community. Because if you're reviewing these plans and you are a diverse representative board, you'll have ideas, you'll be able to help connect the agency into the different populations that they need to connect with. I'm going to go back to that other slide. So with all of the things that happen around community planning, for you all to be part of that, we recommend going to some of these meetings related to the planning efforts, if they're open and, open meetings that the staff is providing, and having a liaison or liaisons from your board there. And then reviewing the adopted Behavioral Health Services Act, the integrated plans and updates, and making recommendations on those as well. You just want to, be listening to what are the kind of comments that are coming from community and ensuring that the plans address those needs. All right, so go to number 5, submit an annual report to the Board of Supervisors. And we underline the word needs and performance. So, talk about needs and performance. Something that could be just the first page. And that's what we recommend, in fact, is to have page 1, which is either an executive summary, or maybe it's a letter from the chair to the Board of Supervisors that highlights the needs and performance. It could, if you've had recommendations during that year, it could highlight those recommendations. And if you're working on recommendations, it could highlight the areas that you're most concerned about, that you're looking closely into in the upcoming year. Number 6 is if you have a vacancy and you need to hire a behavioral health director, your board should be part of that process. And the county staff doesn't always know that. You have to let them know that you should be part of reviewing and making recommendations on the applicants for behavioral health director. So, we would say review, be part of that process. Usually the Health and Human Services Agency director or staff member will lead that effort, and they'll pull people from multiple agencies and sectors in the community oftentimes in order to be part of that interview panel. And we want to make sure you have representation as well. Okay. Number 7 is review and comment on the county's performance outcome data and communicate findings to the California Behavioral Health Planning Council. And in the last, 10 or 15 years, every year they've put out a survey that they call the Data Notebook, and they'll choose a topic. This last time, the topic was wellness centers. They've had a number of topics. Sometimes it's children and youth, it's been older adults, it's been housing. Anyway, they'll ask some questions around those topics, and it's like Survey Monkey. They'll ask you just to fill that out and submit that to them. I think I mentioned earlier, I don't think they've done a good job with their data notebook. It doesn't focus on performance outcomes. So I'm hopeful that that will improve. They've been advocating that it become better. Our website has information on performance outcome data that we have looked at for each of the counties. I think we may need to update Sonoma County, but it's probably maybe over a year old now, that information we've gotten, but the information is from your own materials. So whatever reports you're getting, like what's inside of the Mental Health Services Act reports, that performance data is on our website. We've just culled that information and put it on our website. So this is just a picture of all of the counties. Basically, we have a link. If you go to performance, then you can select your county, and the categories that we see the most information about are children and youth, criminal justice, employment, hospitalization, and housing.
Could you click on Sonoma?
Glasses. All right, let me just zoom in on this a little bit. All right, so categories that were reported: children and youth, hospitalization, housing, and older adults. It looks like you have some data related to assessments that were done for children and youth. That's on the left side. On the right side for housing, what we have is we have a link to your Mental Health Services Act plan, your 3-year plan that ends in 2026. And then we tell you the page number for the data, page 138. Within the, what was that, the ACT program? Oh, no, that's it's an ACT program, Telecare Assertive Community Treatment. 93% of those served were stably housed. Then there's forensic assertive community treatment with 64 clients received assistance with stable housing. In terms of hospitalization, we have both the Mental Health Services Act plan and then the external quality review report. It looks like we didn't see data in that report, so I don't have anything listed there. But with the Mental Health Services Act plan, yeah, there wasn't a lot of data here under hospitalization. I think your county will probably show more in future years because they're going to be required to. And then older adults had some information for this county with one of the programs just showing an improvement in depression symptoms with one of their programs.
The reason I asked you to do it was because in my looking at the data we've submitted in the past year and in the early draft of the integrated plan, one of the commonalities is we don't have any data. And that's disappointing to me, because not only do they say we don't have the data, they don't really say how they're going to get data. So I'm going to be trying to push it.
Yes, and the state is pushing it too. So
Yeah,
And yeah, right now, we're still at a point where it's just not standardized, but we're getting there. So they'll be required. And there will be both incentives as well as some problems that happen if they aren't providing that information. All right, so I'm not sure how well I'll get back to my presentation, but we'll try.
thank you.
That's okay, sure. All right, so, we talked about this last item already. The additional, yes, additional duties and assessing realignment. And some counties have had the Board of Supervisors give additional duties to a board. There was Yolo County, their Board of Supervisors asked them to advise regarding their public guardian office. And I think that was just a short-term thing, but usually we don't see additional duties because you already have so many. Okay. And then with the Behavioral Health Services Act, I talked a lot about the, assuring citizen and professional involvement throughout the planning process. The second item on this slide is review and advise. So if you vote on a recommendation, it becomes what's called a substantive recommendation in law. And if it's substantive, then a response is required from the behavioral health agency. They can say no, that's a response, but they can say yes also, and they can include it in the next integrated plan. If they don't include it in the next integrated plan and it's been a substantive recommendation, then they have to summarize your recommendation and they have to give the reason why they didn't implement it. And they have to send that in an annual report. They have to put that in an annual report to the Board of Supervisors and to the Department of Healthcare Services. Okay, so that's when you have a hearing and you've made a substantive recommendation, okay? And then you all conduct the Behavioral Health Services Act public hearings. The county has to come up with a draft plan. The first one, Behavioral Health Services Act, is the first draft plans due March 30th. So they have to give you the plan at least 30 days in advance, so that there's a public hearing. So the public has a chance to review it. You all have a chance to review it and then have the public hearing. Honestly, at the point that they provide the draft plan, they're usually pretty close to needing to submit it to the state. So they might be making some changes. This year, since it's required, the first draft is required March 30th, but the actual final draft's not required till June 30th. There is some time to make adjustments in the plan.
Our current schedule is to have the Board of Supervisors vote on our completed plan through the draft hearing on June 2nd. You're getting it in May. It's on the web right now as a draft. So that if you have comments, you can email the department. The budget is not included in this draft. It's all the narratives about the programs in the budget. Finance committee or finance department of the department is not submitted to the whole department, the financial numbers, which are required in the plan. So we're sort of in the early stages of approval right now. And the point in our May meeting, I think it's May 17th, is when our public hearing will end. 30 days before that is when they'll officially open it up. So sometime in April, after that March meeting, I mean, the March is to the state that we've got to turn it in. not to ourselves and not to our board. Because the state will want to make comments on our submission on March, whatever it is. So April 17th to May 17th is the open, I think, period of public comment and us as a comment. And like you said, on the May 17th meeting, we're gonna either put up or shut up. Basically, our last time to be able to make a substantive recommendation.
And the thing is, you can make recommendations on the draft plan, but that's actually not what it says for you to do. It says make recommendations on the adopted plan.
Right.
So you have a 3-year period of making recommendations, okay? That's how long that approved plan is in place. And you can make recommendations on the draft plan, that's fine.
Yeah.
Yeah, I think the issue comes in is that, you know, by the time it's getting close to final deadline, the agency is not able to implement that much. You know, it's already very close and they need to start contracting for all the services, so. It's adopted, and so it's an ongoing, it's not, you know, in June, you stop making recommendations, you start, you know, you continue. And you've had your hearing, so you're gonna start continuing with making recommendations, because they'll always be doing updates and new plans.
They're thinking they're gonna have contracts for 3 years for many of the agencies on June 30th. So any recommendations we make about new services or modifications to current services are basically gonna be moved until their contract's in. So it's sort of like, I understand that after June 30th, we can continue to make recommendations, but recommendations to contracts that are already in place for 3 years are gonna be kind of hard to change.
But make those recommendations, just so you have that record. And then once that next 3-year plan comes up, if, you know, because there may be adjustments, even if there are 3-year contracts, there may be adjustments. And there will be adjustments in the amount of revenue we get in the Behavioral Health Services Act. So continue to make your recommendations. That's what you're here for. You're an advisory board, you make recommendations and keep a record of that in your annual reports. And review that, make sure that carries forward within the next major draft plan.
So I have a question. If we wanted to go to our standing committee and say, here are a few things I've been hearing and wonder about in terms of recommendations, would that be appropriate, or would we do that?
Absolutely.
In a board meeting, or how?
No, the subcommittee was set up to exactly allow people, you, members, everybody to do that.
Okay. Well, I do have a question.
The only thing we have to make sure is there's 4 members of the committee now. We have 11 members of the board, so we can't get 6 members
Right.
in the same year.
So we make, I can't talk to you.
It's supposed to be,
Pardon?
it's supposed to be, we can have.
No, I know it's supposed to, but if we have a majority of the subcommittee is a standing committee, just like the other, posting the topics we can have. I'm just saying if the entire board shows up at the standing committee, we exceed our quorum.
Yeah, I think you're.
You know, it's like a quorum, 6 members of our committee constitute a quorum of this body,
Right.
which is,
Yeah, we have.
from what I understand, a violation of our Brown Act.
But it's supposed to be, we can all meet.
No.
No.
If
you
it's
can't.
if
It's a quorum of the
it's a
meeting.
standing committee, then you can't have a quorum of your full board there. And if you have members on the committee, they can talk to each other during the meeting, but if there's people from your board that come to the standing committee, they're supposed to just observe, they're not even supposed to give public comment.
Oh, then how do we then communicate what we think to the standing committee? If we don't go to the meeting, how do we do it?
Well, I
What is the-
suspect you could
I
write.
think through your full board meeting would be the time to communicate and.
No, by an email.
You could, yeah, you can email the committee, email the chair of the
Yeah,
committee.
That's what I would hope you do, is let us know what you're thinking long before you get to the board.
We
We don't understand, so.
we just often get to that subcommittee as, that. And I was told, yeah.
Yeah, you got 3 more meetings before we're gonna get to a point where the full board would be making recommendations, and every month we're gonna be meeting, so. Staggered.
And we do report back with the main meeting.
Yeah, sure.
Are you reporting, the standing committee is reporting to the board?
Yes,
Well, when they do that, then can we
you
comment?
can comment on our comments, yeah.
All right, that might be the best way to do it. Okay.
I just think every time the, either subcommittee meets or the full board meets, there ought to be a conversation about what we're seeing, feeling, and
Yeah.
making the recommendations.
Okay.
All right, this is the last, I think I've gone over my time, so let me, can I have a few minutes?
Yes, I will see you.
Okay.
Sorry.
Okay. Okay.
Take care.
Thank you so much, everybody. Thank you. It's been very informative, and I'll see you Tuesday.
Thank you.
Yes.
Okay, so this last slide is just suggestions on reviewing and evaluating, remembering you're experts in your own experience. We want you to feel, confident and just lead from your experience. But these are areas that we suggest you look at. One is accessibility, making sure things are culturally relevant, scaled throughout Sonoma County. Integrated with maybe other sectors such as primary care or schools, maybe senior centers, just integrated in places where behavioral health services are needed. Communicated, that could be communicated, like advertising on the sides of buses or billboards or on the internet, social media, but it can also mean just the signage. Sometimes we have problems with not being able to find things, especially when somebody's in an active crisis. They need to be able to see the sign, know where the entrance is, and get in. And that can be an issue sometimes. So look for that, especially if you're doing a site visit or if you're looking at a new facility. Recommended practices, client and family driven is an important component where peer providers are an essential component. Client and family members are treated with dignity and respect and included in decision making. Program leadership and staff includes individuals with lived experience and family members. And then we have a list of different types of practices, evidence-based practices, trauma-informed practices, and then what's called community-defined evidence practices. These are all on our website. The community-defined evidence practices are a newer form. They came out of what's called the California Reducing Disparities Project, where a number, I think over 30 different community organizations representing different racial, cultural groups had some type of community-based organization where they were providing behavioral health services of some way or reducing the disparities related to behavioral health. And they found their own community defined practices to be beneficial. And then sustainability, making sure that the services are financially viable. I think that was one of the topics that was brought up this morning around the mobile crisis. And then, when you're doing site visits, that might be a question that you ask during that site visit. Or are there barriers? Are there challenges? Do you have, financial barriers to keeping this operation going and workforce sustainability as well? And then performance, of course. So that's my last slide. There's anything that I've shared, we've got links on our website, really invite you to go to that. And you're always, welcome to contact us with questions as well.
Thank you very much, Teresa, for all that information. It was a lot of time.
Yeah.
Thank you guys for bearing with me and each other.
And when is your next meeting?
April. It's in April.
I encourage anybody who wants to go, I always enjoy everyone I've gone to.
Okay, good. Yeah, in Sacramento this time.
Okay, so we will identify our priorities for our issue focus. And so this is what some people can write things down as we speak. They get them back.
Yeah. And if you want to, I have these stickers you can place, if it's okay with you all. I recommend we'll write down the issues you're most interested in, and then you put a sticker 1, 2, or 3 next to the items. So you get an idea of what the top issues are.
I have an issue.
See, so take it out. Are those sticky back?
Yeah.
So maybe
Yeah, we can just pull off.
take one off and you can stick it on the wall. I'll turn off the projector.
Okay.
You can take those. They're like big sticky notes.
Oh, we have.
Yes.
Okay. Now we are with the first one, guys.
Oh, yeah.
We're not going back one.
Do you want to do this?
Good.
Okay. Let's talk about priorities.
First one?
I don't know, but it's a while we have done site visits. So we need to get a feel of the pulse of what's happening in the community. From my angle, from my vantage point, I think site visits should be one of the things we haven't done that in maybe 3 or more years.
We did one.
We did one
Oh.
to the CSU.
Oh, yes, we did one. This is how fun to be doing it. Thank you, that's it. Keep in touch. Okay, that's from one, at least this is one area I think we should work on. It was very informative, I have to see this.
That's great, yeah.
And I would say, the listing on this, of these issues, like related to children or youth or things like that, I would say site visits is a tool, so not an issue itself, but, something to be using and to continue to use, even if it's, you choose 1 or 2 sites a year, that should be just a natural, every year, it should be something that we're doing. Yeah.
There's another set of tools that I just want to throw out there because we don't have the time to do enough site visits for me to get a sense of all the contractors, but I did choose to contact Nolan last year to gain every contract the county has with every service and every report of their performance. At the time, this was July of last year, and they said, we haven't got the contracts done yet, Gregory, but when we do, we'll give them to you. And I said, and when you get the January first 6 months of the fiscal year report of the agencies on how well they performed on the scope of work, could we have that too? And he said, yes. So I'm looking toward gathering and reading the contracts and the reports of performance of every agency we fund. Now, that to me is a better way of trying to get a sense of who's doing what and how well. Which is what I think one of our responsibilities are. So if there's an action item, it's following up with Nolan to gain all contracts and all reports.
But I have a question of that. Isn't that what the whole quality improvement section of the department is for? Would they already have done that work? And we don't
And you
have
can
to-
ask them if he had them at the time, I think.
He would have-
In other words, he may say to his own department, do you have the reports?
Yeah,
From what I understand, the only person who has all the reports or all the contracts is the guy writing the contracts and receiving the reports. Homelessness has one of those characters, but I don't think the department does. But that's what I'm asking.
And
Give
I
us what
think you guys, you're still focusing in, I'm not sure about this idea, actually. I think that's more than a board usually does, is go through 50, because that is a staff. That's usually staff that does it. You're looking for bigger systemic types of recommendations, not for each and every provider, but I understand some of the reasons why, but you're still focusing on those are not priorities, those are tools. So I want you guys to be, or at least I think that's what you have,
Sure.
in terms of what
Yeah.
you should be talking about is where are those challenges in the community that you want to be looking at closely this year?
Yeah.
Like, we were talking about, like,
I have one that,
care programs.
I have one that I don't know if,
Things that's missing,
Right,
like issues
right,
or not, right?
Issues.
so I don't know if this is one, but like, our unhoused and homeless community, at large. Especially if we're moving to integrate that into, behavioral health.
Sure.
And those are gonna be combined, is there gonna be gaps that are gonna show up? Is there gonna be work that's gonna have to be done? That's something that when I was hearing about the integration, like, whenever something gets integrated, there's always like issues, problems, gaps. So is that gonna be something that's gonna be of our, something that we would be dealing with?
I think that's an issue,
Yeah,
like
that's
you
an
just
issue.
brought up, and that might be something that you make sure that you put it periodically on your agenda to get updates from staff on that.
Yeah. And the reason I asked for the contracts and reports is that's where I get that. Having filled out those reports, you tell the department.
You're asking for a lot though from staff that is really, it may be confidential information.
It's a public record act request, and I can't imagine why
Well-
Ellen would have said, I can't give you that if it wasn't something I could get. We'll find out. If he says I can't give it to you for privacy or whatever, we'll find out.
So technically, we only have one issue up there.
so I have an issue,
Mhm.
and it's kind of a small one, but I think it has a major impact is the access team intake.
Yes.
I listened as my son was being talked to over the phone and assessed a couple times, and the questions are just ridiculous and don't get to the point, and by the time they do get to the point, he's lost interest and doesn't understand what they're saying, and or he was able to weasel out of it when they say, do you have any DUI issues? He said, no. Yeah, have you ever had any DUIs? And he said, no. And they said, okay, well, that wasn't true. So, yeah, the intake interview.
And it's one of the biggest issues from the homeless coalition's point of view of their perception of the mental health system. There was a huge discussion last week between the coalition and the department over that, over access to, especially moderate mind. I mean, everybody the people in the homeless coalition who have clients who are serious mentally ill are figuring out ways of getting them into the access. That's only about 10% of their clients. The rest of them who are going to be major, but aren't yet, they're worried about it.
Also supports for our youth that are gonna be losing all their behavioral health, counselors and everything at the schools. That's obviously we've had comment at our meetings about it and stuff like that. So that's gonna be huge in the coming year for sure. So,
Yeah.
so,
School access.
yeah.
Yeah, access to access by either youth or folks in the system that aren't there yet.
Wow.
I know we have addressed the Hispanic community to a certain extent, but I'm not sure how
Outreach.
those outreach, how effective those outreach are, and what percentage of those in need of services that we actually need. I think what makes it even more important is we don't have many people in that from that community on the board to be able to tell us what the lived experience is, what is actually happening out. Standing things outside looking in is not the same as in looking at. We need people who are in to tell us, those of us looking from outside, what's happening. And what might be an approach to it, or what might be effective, or what their needs are. It's one thing to say, I see this is your need, but when you speak to the person, it's like, that's good, but really, this is what I want. And we should go for what they want rather than what we think they want, because that's what will make a difference in their lives and in terms of not only access, but compliance to whatever it might be. So I think.
So meeting them where they're at instead of meeting them where we think they're at.
Yes.
Yeah.
And I can speak to that a tiny bit. Mental health is a very taboo thing in the Hispanic community. When I have dealt with families where I have mentioned, oh, our access team can, no, we don't want our neighbors to know what's going on. We don't want the vans pulling up. We don't want anything that lets anybody know that we are trying to access these, services. It has to be quiet. So it makes it very difficult. A lot of information is not translated. A lot of information is not, easy, how should I say, to digest. We get caught up in the lingo, and a lot of times it just goes over a lot of people's head. It needs to be easy to understand. And so, yeah, making our services more accessible, and addressing that taboo is huge with the Hispanic community.
And what was it? There is an agency that's starting to do that, and I can't remember. Where they're having conversations with people on a more community level.
Well, we did it when I was with Seneca. I met people at coffee shops. I met them at the park. I would have breakfast with them. I met them wherever they felt comfortable, and it felt like just a conversation amongst friends than an intervention. So I think that's so
and in the discussion about deportation at the board, Parita, a lot of Hispanic groups are coming saying, even meaning North Bay organizing, lots of others are beginning to say, we need more translation, we need more staff hired who can speak in their dialect, to clients. So how we improve our communication in general is something that obviously you're putting up there, and I support, because for the longest time in the medical community, and Pearson would certainly attest to this, we were talking to their kids.
Yeah.
The only people we could speak to in the language they can understand was the 12-year-old who was coming along with his mom. That's not good.
Which is not good, it's problematic.
No, big problem.
It's problematic. It's something that I have fought over the years when I see it, and I call people out when I see it up to this day.
Yeah.
10-year-old was like, no, can you have a seat? I need to speak to him. Get a translator. Because there are things that will be sometimes much, much too heavy for this child to even be exposed to or to be translating to, and they have to go back home.
Right, and we don't know if they're saying.
It's not accurate, I think.
Yeah, no, it's not accurate. I'm many times not accurate. Even sometimes I know a little bit of Spanish, even when the translator's like, that's not what I asked. You.
Yeah.
I asked you to translate this for me, not translated that to you. Didn't do what I asked you to. So even that sometimes can be problematic. So
But how hard it is to tell someone they've got a medical condition, think
Right.
about the mental health. Yeah, think about substance use. I mean, it's so much harder to be able to get someone into that conversation.
Or saying, we have this written out for you in Spanish and handing them, like you said,
Yes.
and if they can't read it, and not everybody
The
even
lingo
has
is
literacy.
it's difficult to
it
understand.
is hard. It is, I'm a specialist in substance use. Some people first, you have to get to, they have to get to the point of accepting there is a problem.
Mm.
And if you're going to expose them with the kid that there is a problem, then the kid might take that on. So this person has to be in a place where they themselves can accept that there is a problem that needs to be addressed. Because when you know, which you don't want to burden that child, you don't want to burden, a 12-year-old or a 10-year-old with all of this. So we need to do a lot better.
And I think it's also important to understand the fear in the Hispanic community right now.
Oh, yeah.
With everything that's going on, they're afraid to go to their appointments, they're afraid to go anywhere,
And we
even
can't
to the
guarantee
store.
that it's safe.
And we can't guarantee that it's safe, so like,
Even
that's-
citizens,
yes,
that even
yes,
citizens, that,
yes.
it's crossed the
They're
board,
scared to send their children to school even, so it's
for sure.
a huge thing.
It's an issue, so I know. What else can you?
The court system and the jail system becoming the providers of mental health care. Just by default.
So how, can you,
So I've,
uh,
so for example, for my son, he has anosognosia, he doesn't think he has any problems. And the only time he gets any kind of treatment and intervention is when he's in jail. And that shouldn't, and they're doing as best as they can, and I think we're depending too much on the jail staff to do that. And they're actually doing, I think, a pretty good job, but that's not their role. And then I see in the courtroom, maybe it's a separate thing too, the judges needing to have better training about who they're talking to and what they're saying in this public space to people who keep coming back and back and back, and they don't have the capacity to handle themselves, and the judges don't really know how to deal with it. And
There is a bill right now around that. I can get that to you.
And we provide training, it's called CIT training to the sheriffs.
Oh, yeah,
How
and
to deal with it,
they're doing a great job.
which is amazing.
But it shouldn't be their job.
No, it shouldn't. You're right.
I've been meeting with jail staff. I've been really amazed by how dedicated the ones are who choose to, it's their choice to work with the population. And they've been so dedicated and so accepting and friendly and really getting to know the inmates, but that's not their job.
And we have a couple of programs, Crossroads to Hope and others that are trying to deal with people on their way out. Trying to figure out a way of helping them so they don't return.
Yes.
And to place them in housing and other support services so that they continue to recover.
And don't keep repenting.
And don't-
offending.
Right.
We've also got education in there too, through Rising Scholars and through that program, Project Rebound stuff, so. One thing that keeps, I keep thinking of, not only, even outside of here is, especially when I hear about things like funding sources and stuff like that is, especially because I work with, a few different local nonprofits is, that's where a lot of the work is gonna fall on when we lose a lot of funding is our local nonprofits. So fostering relationship and support for the ones in our community that are doing some of this work. Like I said, Michael's Hugs and others, Equisense, those would be, I feel like that would be, something that would be good for us to do as a board. I'm not sure if that's
Well, the real crime is that they're gonna lose their money before we do. Community agencies
True.
are gonna be the first ones cut,
Yeah,
so.
as far as grants and stuff like that.
Yeah,
Yeah,
it's a whole lot easier for us to just not issue any community support grants than it is to fire our own staff.
Yeah.
And,
Yeah, right.
or stop something that we just started last year because it built up to a need and we found the money.
yeah,
I'm worried that there won't be anybody left to recover our folks because we'll have already killed them as agencies.
yeah.
So you're right that we need to support them. And sometimes we have to make tough choices over whether they still exist.
Yeah.
Any other issues that?
One more.
No, then not limiting you at all.
Dual diagnosis, treatment for people who have both substance use disorder and mental illness. Even the places that say they're doing it, they're not really doing it.
Okay, so we have 6 issues. The first 2 we said they were not issues.
Tools.
Right.
So draw a line after number 2. No,
Through
2,
number 2.
yes. And 1 as well, 1 and 2.
Yeah,
Okay, so these are the issues that we come up with.
I'll be bringing them back up as everyone does.
Okay, so I think each of us received one of. So let's put what we think would be priority from our angle, individual person.
Okay.
And see which would be the top 3 we would want to tackle.
Green, purple, and red.
1, 2, and 3.
Green is 1.
Yes, no, yes, green is 1, purple is 2.
Purple is 2.
Yes.
Good one.
I'm colorblind, so thank goodness I have the numbers.
The numbers are there.
The numbers are, you can, you know, with the crime.
These 3 documents, most of the right things to give.
I really think you know a lot.
Might be an applicant.
Okay.
I'll give you my copies.
I've saved them to my little folder for the behavior report. What you sent me in that email.
All right,
Great. I wish I represented me. So that you could send. It would be perfect.
Choices, very good choices. Okay, so here we have it. Yeah.
No surprise there.
It looked like number 1 on the list here would be homeless integration. Behavioral health. I'm not sure what the impact will be, but this is number 1. It has 4 number 1s out of 6 of us. No, okay. Followed by school access, which have 3 of number 2. And the Hispanic community as well as the dual diagnosis, both of them have 2 phrase.
As well as access to mental.
Access
Number 4, right underneath homeless integration.
Oh, okay.
They're all important.
Yeah.
But you're gonna give a report to the full board on Tuesday as to what you decided, right?
So,
Well,
I mean, I think it's logical, it's easy.
I've got a picture I can email you.
I can take a picture, or I just take the whole thing.
Right. Yeah, the whole, I mean, this will guide you in terms of, your next steps this year.
Yeah.
And maybe all of those things could be
Yeah.
considered throughout the year. It's just, what the top issues are.
would be, and as a, so we should have a picture of this.
Yeah, I'm gonna take
Yeah,
it
you ready
and
to
I'm
take
going
this?
to type it out, nice and neat, and
Now, granted, sorry for calling you guys, and it's okay, it's not a gender guidance. Bear in mind, this will take some work.
Sure.
And this will take some commitment to address or to make ourselves available, make commitment, whether it is writing letters, talking to the team, going to places. This is not a one-man show. So I am, how do I say it? There's an expectation that we will do that as a combined unit.
Yeah.
All right.
No, we're not expecting you to do.
No,
all of it.
There you work.
I didn't think you would think that way, but I'm just saying. I just said, the expectation is we will show up when we need to show up. We need to commit to the time, we need to commit to the cause in order to be able to deliver to the people of Sonoma County in those areas of issues.
Which reminds me, we had talked about having name tags or business cards. And I'm wondering what other counties have done, what other county boards
Or shirts.
have done for when they go out in the community to identify themselves as a board member.
Right, right. Yeah, well, usually, they don't have their own name tags, but some large counties do. And when you are going out into the community, you've organized an event or you're representing something, so. They
Or when
know
I
who
go
you
to
are,
an event,
right?
No, they don't.
What about a
They don't know
shirt?
who we are.
Is it okay to get shirts?
No,
No.
I like,
Like shirts.
I like tags.
Tags.
Yeah,
Like, if I go to an event, a community event, and I want people to know that I'm there, not just as an
The thing
interested citizen,
that you have to be, oh, sorry.
but to say I do have a role and come talk to me, because I have some, like, when elected officials go out there, they have some kind of identification too.
I would just be careful that you're representing the views of the board. It's not very often you're gonna actually have a recommendation from the board. So you're representing the board in terms of showing up, but your words won't, unless it's related to the work of this board and a recommendation that was made by the board. That's where you have to be careful. If you're wearing a name tag, you're representing the board. So,
Makes sense.
So I'm sorry, you through?
yeah.
I was just gonna respond on Peterson's comment that this is a group effort. And I'm not speaking for Alexander, but I'm gonna try and integrate those things that we said we're gonna work on as part of our annual report to the board of supervisors. I think that's one way in which we can keep it in our minds and keep it in their minds and report on it. Now, I also, though hardly any recommendations have ever come out of the old mental health board, except unless somebody was being unfunded and they wanted to keep them open. I fully anticipate this board to increase the number of recommendations because I see the quality of the people in this room and their commitment, and I think they're going to be passionate about some things that are going to take place and how they communicate that and how they ask the public to give them more information is gonna be experimental and pretty innovative. So I wouldn't second guess how many people are, or how many recommendations we're gonna have yet, because I think it's something to watch for.
Okay. I'm excited. I have to say thank you all for coming to the and participating, and thanks again, Teresa, for going over the Brown Act and guiding us through the expectations. I know a lot of times people would say, why am I here? What am I supposed to be doing? I'm blank. I'm hoping today was a good educational exercise. Set the stage for especially those who have been around. The very new ones, or those have been the relatively new. And like me, a refresher out of the Brown Act, many times they have had me in most of our retreat, we talk about it. So I feel really new. I hope you guys are as well. I may not come July, I may not be the chair, so but that doesn't mean because I'm not the chair, I'm not part of the board. To support whoever is taking over from me as well in the next 5 or so months. So really work towards our commitments to outcomes in the future.
Yes, well, I was just gonna recommend that as part of your agendas, you might have a listing, maybe it's on the last page. That shows the priorities that you set for the year, just to have it either on your executive committee agenda or on the full agenda, just to keep it as a reminder as you move through the year.
And while we're making recommendations over what we ought to put on our agenda, I've always thought that we ought to put our bylaws duties so that the public knows what we're supposed to be doing in general from the Board of Supervisors. So we have this little who we are thing, which I think has been made up from what we thought we were in the past. I'd like to see that replaced with this kind of direction to the public as to what we think we're doing.
Okay, no further comment. The meeting has been adjourned. Thanks again. Thank you, Sapta, for the lunch and the snack.
Thank you. You're welcome. Thank you.
That's very important about you.
Have this very smooth.
You too.
Good. Thank you.
And for the board members, I'll suggest when I find out Tuesday.
Yeah, okay.
5 o'clock.
Yeah, that was great.